Good afternoon and welcome to this bill hearing for the House Health Committee. I'm Delegate Heather Bagnall, Chair of Health. I ask for your patience if we encounter any technical or streaming issues. Now, this hearing is being streamed on the Maryland General Assembly YouTube channel. We do have a few virtual speakers today. Also, please note that food and beverages are not permitted in the gallery. Delegates may have drinks at their desks as these meetings can run quite long and hydration is necessary. If a member is not present, please understand that they may be attending other official meetings. We do have bill hearings in other committees, but they will make sure that they remain informed on these proceedings. Please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from each panelist. And please keep your questions brief and shorter than the answers. Also, we will be going in this order for the bills today: House Bill 272, followed by House Bill 274, 276, 279, 42, 158, 7, 196, 380, and 377, with discretion as we have people that that come and go, obviously. Also, our committee rules, once again, are that sponsors are not limited in your testimony. You are not time limited in your testimony, but please keep it within reason so we don't have to revisit that. All witnesses have 2 minutes. We're going to start with House Bill 272, which is food establishments, lavatory requirement, and on-farm food service facility license. If you want to come to the table and you can go ahead and get started. And welcome, we have a plethora of secretaries today, so it's just very exciting to have in our committee.
Yeah, we'll go in order. Okay, good afternoon, everyone. Good afternoon, Chair Bagnall, Vice Chair Cullison, members of the committee. It's wonderful to be here with all of you today. For the record, my name is Dr. Mina Seshmani, the Secretary of Health for Maryland. And my team and I are delighted to be here with you today, with the Department of Agriculture as well, and my Deputy Secretary for Public Health Services, Dr. Meg Sullivan, to discuss House Bill 272, Food Establishments, Laboratory Requirement, and On-Farm Food Service Facility License, which is ultimately designed to help Maryland farmers continue to provide the value they do for Marylanders in a way that is efficient and allows them to grow their operations. In light of the concerns that have been brought to our attention, it is clear that the farm community faces difficulties when acquiring food service licensure for wineries and farms. Currently, an on-farm food service facility license is limited to not more than 30 consecutive days, with up to 2 renewals in 1 year, according to statute. However, agritourism facilities often operate differently from that. They could operate on weekends throughout their year or for more than 3 months, and yet they still may not be a full-time food service facility. So the Maryland Department of Health, in close collaboration with other agencies in the Moore-Miller administration, in particular the Department of Agriculture and the Department of the Environment, we have worked closely with the farm community and many others to propose changes to the on-farm food service facility license to make it a renewable 1-year license, which more readily allows for multi-season food service. Doing so provides a clear mechanism for farmers to provide food services on their farms in a variety of settings and operate more flexibly throughout the year without having to repeatedly apply for licenses to operate. Most importantly, this bill will provide the farming community with a predictable and logical roadmap to grow from small, limited food service operating only a few weeks a year into a more sustained operation, operating multiple seasons, and one that generates significant benefit to the farm. The aim is to do all this within reasonable boundaries that protect public health and ensure the farm continues its primary agricultural activity. The bill will rely on regulations that will be drafted in a transparent, open process involving public stakeholder input and public meetings, which will be discussed in greater detail by Deputy Secretary Sullivan in just a few minutes. And again, we are excited to be partnering with the Department of Agriculture on this effort to ensure that agricultural businesses interested in obtaining this expanded license are able to do so in a streamlined manner. So with that, I'd like to turn it over to Deputy Secretary Sullivan. Thank you again.
Thank you, Secretary, and Chair Bagnall, Vice Chair Cullison, and members of the committee. I am Dr. Meg Sullivan, Deputy Secretary for Public Health Services at the Maryland Department of Health. Thank you for the opportunity to be here today to talk with you in more detail about our vision for the regulatory process and resulting regulations for House Bill 272. You've already heard from the Secretary about the intent of this bill to address some of the challenges of expanding food services operations on farms in prior years. And to reiterate, our goal with this bill is to increase the clarity and flexibility of on-farm food licenses to better support farms and the communities they serve, while continuing to ensure the appropriate public health protections are in place. I want to acknowledge that our three departments have already done a significant amount of work with stakeholders to get us to this point, including the farm community, the Maryland Restaurant Association, the Maryland Association of County Health Officers, the Governor's Interagency Commission on Agriculture, and others to understand these challenges in anticipation of both the bill and the regulations that would follow. In particular, we want to acknowledge the important voice and role of local health departments who work with farms on licensing every day. We look forward to a regulatory process that involves a broad array of stakeholders, not only those I just mentioned, but also local governments and community partners, the business community, and more across the state. We are committing to you today that this process will be open and transparent and have public meetings for stakeholders to ensure that local communities and interests are taken into account. The bill purposely relies on the regulation process to determine many of the specifics, as this will allow the most involvement and ability for input from stakeholders and sibling agencies. We anticipate that the regulations would address some of the challenges that have vexed both farm business communities and regulators, such as an on-farm food service operations expand in scope, frequency, and/or number of people served, how do we ensure they can do so with appropriate public health and environmental consideration? How are existing structures on farms evaluated for use for food service? If and at what point does an on-farm food service facility become more like a restaurant and need to be regulated as such? In order to ensure a smooth transition, the bill maintains the current on-farm license until the effective date of January 2027 to allow for the regulation development process. In conclusion, Madam Chair and members of the committee, while we have no illusions about the complexity of the task, we are committed to a process and a product that meets the needs of our state's farmers and the public who visit them to take advantage of the opportunities they offer. And we respectfully request a favorable vote on this bill. I'd now like to hand it off to the MDA Chief of Staff, Harrison Palmer.
Great. Thank you, and thank you, Madam Chair Bagnall, Vice Chair Cullison, all the members of the committee for the opportunity to testify on behalf of House Bill 272. For the record, my name is Harrison Palmer, I'm the Chief of Staff at the Maryland Department of Agriculture, and we really want to emphasize the collaboration and the work that we've been able to do together between both the Department of Health, Department of Agriculture, and within the Governor's Intergovernmental Commission for Agriculture that was revitalized in 2025 to put emphasis on farm profitability and agricultural sustainability in the state. The commission itself was tasked with prioritizing the ag's viability because we recognize that Maryland agriculture is still the leading commercial industry, but continues to evolve over time. And having regulations that make a clear and scalable process are critical to the success of the industry. The commission, the Department of Health, have all been proactive in ensuring that farmers have clear, scalable policy referencing the Department of Agriculture's statewide guidance document for agritourism and value-added agriculture that was published in October of 2025 after nearly a year of engagement and collaboration between partner agencies, local jurisdictions, farmers, restaurants, and anyone who could be touching the on-farm sector. In identifying the challenges within the statewide guidance document, we recognize that regulatory scalability is a major challenge for new and expanding farms that are exploring agritourism as an opportunity. House Bill 272 directly addresses this challenge specific to on-farm food service and establishes an option for farm operations engaged in agritourism that recognizes the seasonality and unique infrastructure of the underlying agricultural enterprise. With that, we respectfully request a favorable vote on House Bill 272. Thank you.
Do I have any questions from our members? Delegate Shalega.
Thank you. Thanks so much. So to clarify, is this going to replace a variety of local permits and fees? So we're consolidating this. This isn't adding yet another layer of government, is it? One person may answer.
No, yeah, so the idea is, again, right now, we have a couple of different options for the on-farm food license, but one of which is the temporary food license, the event license, which we would still keep. And then we have a full restaurant license. The current on-farm food license is 30 days limited to two-time renewal and has a lot of limitations. This would replace that, yes. It would not add it in a new one.
Thank you.
Vice Chair Cullison.
Thank you, Madam Chair. Thank you for being here today. I'm looking at the suggested amendments from the Maryland Association of Counties. Have you had a chance to see them? And where are you standing on those, or further discussion needed, or?
Yeah, I mean, I think hopefully what was clear from our testimony is this hasn't really been a collaborative process with stakeholder engagement. We can continue that or expect that to continue. So we have had the opportunity to briefly see them. We are continuing to review and plan on engaging Mako throughout and giving it full consideration.
Great, thank you very much.
Delegate Johnson.
Thank you, Madam Chair, and thank you for coming to speak on this bill. Do you see this bill in any way fitting in with our rural transformation policies? And will it help?
I can take that. Thank you for that question. I think how it fits in is with our broader approach for how we are blending the importance of healthcare in our rural areas with bolstering the local economy. So where, for example, in the Rural Health Transformation Program, we will have funding that we have been working with the Department of Agriculture to put towards things like cold storage and food processing. That bolsters a farm's economic, well-being. This provides another avenue, a streamlined avenue for farms to be able to provide more value to communities as well. So they work very much in partnership towards that broader goal.
All right, thank you. Thank you, Madam Chair.
Thank you. Delegate Hill, followed by Delegate Gazzoni.
Thank you very much. I just want to, since you're not going to get another chance to go at it, Worcester County had some concerns. Okay. And it sounds like you may have addressed them, but I just want to briefly tell you what they are saying. Local departments are still waiting for the completion and implementation of other regulations from previous bills without aligning regulations to avoid conflicts with existing rules or even a time frame for their adoption. The LHDs will have no answers for the public when they have questions and they want new laws implemented. They want to see a pathway for local environmental health departments to have a seat at the table, which sounds like they may already have, and then it locks in the $100 fee. There are noted fiscal concerns that the local agencies will have trouble meeting enforcement responsibilities within existing resources, so they're concerned about that being locked in, and they're not having any flexibility to adjust that locally. And then it says, we urge you to provide an unfavorable report without significant amendments to correct regulatory inconsistencies and provide county agencies with a fee. So if you can address those concerns, or if those are already things that you're looking at, or if those are things you'll consider looking at.
So, and I think as you noted, we addressed some of them, really understand the complexity of the regulatory process. This is something that we are absolutely committed to, have already started mapping out and, plan on having not just local health departments, environmental health directors, but so many stakeholders at the table, and that is a firm commitment. I think as Vice Chair Cullison mentioned, we are aware of some amendments that we are looking at, and again, we'll be engaging stakeholders throughout the process to continue to talk through that.
And the fee, did you have a response?
That is something that we're discussing.
All right, thank you.
Seeing no further questions, thank you very much for your testimony. It's always a pleasure to have you in our committee. Madam Secretary and Mr. Secretary, I now have a favorable panel of Pamela Tenemaza, Jeannie Hadaway-Riccio, Tyler, is Tyler Huff? Yes, Tyler Huff, and Megan Lynch. I wasn't seeing her. Megan Lynch is just here for questions. Thank you. And you can begin when you're ready.
Madam Chair, Madam Vice Chair, members of the committee, for the record, Tyler Huff, Maryland Farm Bureau, here in support of HB 272 today. You've already heard the outline of the bill from the original sponsor panel, but I want to go ahead and hit on some key things. This bill, it shows a streamlined effort between multiple departments to help work towards a solution that the agriculture community, through, I'm going to abbreviate to GICA, but you heard the Governor's Interagency Commission on Agriculture, has been discussing for the past few years. It offers a streamlined licensing with a notable cap on license. Now, yes, that cap might move a little bit up. I understand that's one of the concerns in the amendments, but a streamlined cap that makes sure the producer understands the affordability. And the big piece I really want to hit home is opening the door from a 6-month license to a full year-long license will help those on-farm producers. Currently, while many of those producers are seasonal and only seasonally open, there is some layover that is challenging depending on when you have to get your license, that there could be a window of opportunity or a window where you're open without a license because you're waiting on a renewal or you have to apply for a new license in a certain case. So that year-long license, while many are seasonal in their type and kind, would allow for more security for those producers. It also, with the regulatory process being still to come, I think there's a great opportunity for stakeholders of all kinds, including those that are actively involved in this day-to-day, have the ability to make sure that their voice is heard and that it's been shown through this initial process that they are being heard and they are being listened to. So that being said, on behalf of the members of the Maryland Farm Bureau, I respectfully ask for a favorable report on HB 272. Thank you.
Thank you very much. And do I have anyone else on the favorable panel that I did not call? Yes.
Thank you, Madam Chair. Tyler, registered artist.
Okay, perfect. I just want to make sure. Any questions from the members? Delegate Hutchinson.
Thank you, Madam Chair. I don't know whether they're coming up to testify, but and it probably should have asked it the first panel, so if I catch off guard. I see there's a letter from MACO in here with some amendments. Are they favorable with this bill?
I have not seen the MACO amendments. I would encourage you to reach out to the Department of Health. We talked this morning briefly, and I think that they're working through with them. I believe Carrington is coming to the table here later still to come, but we have not seen them, but I would relay to those on the initial panel, and we'd be happy to work through those amendments.
Thank you. Thank you, Madam Chair.
Delegate Rosenberg.
If I could, thank you, Madam Chair. Speaking in my capacity as Chair of AELR, which would review the regulations, that we look to the views of the Chair of the committee that heard the bill, that the regulations are responding to. And so is there an adequate legislative history that you're, in terms of the documentation, testimony, written testimony for the bill? Perhaps this is best asked of the Health Department.
From my standpoint, a lot of the conversation about regulation has been done through GICA. I apologize to abbreviate, but the Governor's Interagency Commission on Agriculture, which Maryland Farm Bureau does have a representative on. I know a lot of the conversation has gone through there, but there's also been further conversation In years past, MDA has a specialist for value added who has been a key piece in starting this conversation and being able to advocate for what those members that are doing this and obtaining this license are looking for. I would also recommend discussing with MDH on that regulatory process. As that original license was done before my time here in Annapolis, so I am not familiar with how that initial process went, but in my years down here, it has been an open line of communication between agencies with stakeholders, which is absolutely encouraging for how the regulations are going to be done.
Okay, thank you.
Thank you very much. Seeing no further questions, thank you for your testimony.
Thank you, Madam Chair.
We have one favorable with amendments, and that's Carrington Anderson.
Thank you, Madam Chair and members of the committee. My name is Carrington Anderson with the Maryland Association of Counties in support of House Bill 272 with amendments. I do want to thank the department for working with us. I do think we're really close on some of our concerns, and counties do appreciate the flexibility that this gives to food establishments, particularly with the loosening or making it a little bit easier for the laboratory requirements. We do think that will help food establishments. Some of counties' concerns is that there's a lot of broad authority given to the department, both MDH, MDE, and the Department of Agriculture. And because so much of this can have a big impact on county operations, we just want to ensure that we have a seat at the table. We've gotten a lot of feedback from our local environmental health directors and our health officers, and just want to make sure we have a seat at that table. Additionally, we just want some clarifying language and want to make sure that nothing in this bill or the regulations would preempt local zoning. And then one of our significant concerns, and we know it's not the intent of the bill, but again is where we want that clarifying language, is the language that has to do with assessing the current or planned physical structures. That's similar language in a bill that not this committee, but the General Assembly has considered several years with a tax bill over property tax assessments for agricultural land and improvements. And that was a bill that MACO had significant concerns with and was something that SSTAT had a fiscal impact of roughly $300 billion to local governments. And again, after speaking with MDH, we know that's not the intent, but we do think that that warrants some clarification there and think that our amendments address that. So really do appreciate working with the department and the committee, and I do think we're very close here. So for these reasons, MACO would respectfully request a favorable with amendment report on House Bill 272. Thank you.
Thank you very much for your testimony, and I was seeing a lot of head nods from the table sitting behind you. So do I have any questions from the members? Delegate Johnson.
Thank you, Madam Chair, and thank you. So you talked about zoning. Wouldn't that be up to the county or the zoning and where these things would be able to operate or not?
Thank you, Delegate, for the question. Yes, and we just want to ensure by adding some clarifying language that nothing would happen with preempting local governments there.
Okay, thank you. Thank you, Madam Chair.
Seeing no further questions, this concludes your testimony. Thank you very much. And it also concludes the bill hearing on House Bill 272. We're now going to go to House Bill 274, which is the State Board of Environmental Health Specialists Sunset Extension. If you want to go ahead and come to the table, I have Megan Lynch and Lee Broderick. Is that? And you can get started whenever you're ready.
Good afternoon, Chair Bagnall, Vice Chair Cullison, and committee members. For the record, Megan Lynch, Director of Government Affairs for the Maryland Department of Health. I'll be very brief here today and just say some very high-level pieces, and then I'll turn it over to the board's Executive Director, Lee Broderick. House Bill 274 is a departmental bill for the Department of Health, and it extends the termination date of the State Board of Environmental Health Specialists for 5 additional years through July 1st, 2032. And we respectfully request your favorable vote on House Bill 274.
Thank you. Thank you, Megan. And thank you, Honorable Delegate Bagnall and the committee members. My name is Lee Broderick, and I serve as the Executive Director for the Board of Environmental Health Specialists. Our board licenses environmental health specialists in Maryland, many of whom work for local health departments, and some actually work for private industry also. They all have the mission of protecting public health by controlling environmental hazards. They're the professionals who make sure that the food you eat out at restaurants is safe and buy in the store is safe. They inspect public swimming pools and spas and bathing beaches, investigate rabies, possible rabies exposures, and help make vaccine available to the public. That's a big part of what I served in this capacity for 31 years for a local health department, and much of mine was involved with individual wells and septic systems where we're trying to keep the groundwater safe. We issue the permits for those. So to be licensed to do this essential work, they have to have certain education and experience criteria that they meet. And our board staff make sure that that happens. We review transcripts and their applications, and we track training to determine their eligibility for license issuance and license renewal. In addition to issuing and renewing the licenses, the board staff is also responsible for other day-to-day activities of the board and coordination of administrative functions. And we're able to accomplish our mission economically with assistance from staff that serve the other health occupation boards, fiscal, investigative, and so on, IT. The board itself has 9 members. They're appointed by the governor with the advice of the secretary and the advice and consent of the Senate. Membership includes 7 licensed environmental health specialists and 2 consumer representatives. The board sets standards for the profession, adopting and revising regulations, and also we have a code of ethics for the practice defined by statute, which we also enforce when there's a complaint. Like I said, I worked for 31 years in this field. I'm proud to be associated with a profession that preemptively strives to keep our citizens healthy and safe. And the board supports HB 274 and requests a favorable report to extend the board's sunset to July 1st, 2032. And I appreciate the opportunity to testify.
Thank you very much for your testimony. Are there any questions from the members? Seeing none, thank you very much. Oh, I didn't see your light. Delegate Rosenberg.
Thank you, Madam Chair. Have you received any evaluation under the Program Evaluation Act?
I'm not aware of any. I'm pretty recent. I'm not aware of one recently.
Delegate, we did receive, if I may, we did receive a question on the Senate side to that effect, and we took a look, and we have not received any requests from OPEGA for an audit.
Okay.
Thank you.
Thank you.
Delegate Hill.
Thank you. Just for completeness, the last time you all were renewed or the sunset was extended was how long ago? 3 years?
It's every 5 years.
Every 5 years, okay. And there's no, you don't think there's a need to have any change in your charge or anything like that, or all those things are fine as they are?
I think things are good. There's, minor tweaks to the regulations that I expect.
You can do them through regulation. And this new thing called pyrolysis that we're using, that there's an experiment going on near my district having to do with PFAS and how we manage PFAS. Is that something that your specialist would also oversee, or is that something completely outside of?
I probably have to get back to you on that. I don't think we'll have direct involvement, but in terms of like maybe some water sampling or something, we might have indirect involvement, but I'm not sure.
Thank you.
Okay. Taking a moment, making sure I didn't miss anyone. All right, thank you so much. Seeing no further questions, this concludes your testimony and concludes the bill hearing on House Bill 274. We're now going to go to House Bill 276, State Emergency Medical Services Board, Public Access Automated External Defibrillator Program revisions. If we can go ahead and I believe it's Theodore Delbridge. If you want to go ahead and come to the table and start your testimony.
Good afternoon, Chair Bagnall, Vice Chair Collison, members of the House Health Committee. Great to see so many familiar and friendly faces. I'll say even though the committee name on the door might have changed, I'll always It'll always be HGO to me. But on a serious note, thank you for the opportunity to be here with you today. It's nice to be among old colleagues. For the record, Christian Mealy, Director of Governmental Affairs for the Maryland Institute for Emergency Medical Services Systems, better known as MIMS. And I'm pleased to present House Bill 276 on behalf of Dr. Delbridge, our Executive Director, who's actually across the street as we speak, to testify at our agency's budget hearing in the Senate. For the benefit of those who may not know the full scope of what all we do, MIMS is an independent state agency that coordinates all components of the statewide EMS system in accordance with policies set forth by the EMS Board and Maryland statute and regulation. Our areas of responsibility include medical oversight, promulgating statewide clinical protocols, coordinating and supporting EMS educational programs, licensing and certifying Maryland's approximately 20,000 EMS clinicians, which is the heart of our system. We operate a statewide communications system. We designate trauma and specialty centers. We do the licensing and regulating of commercial ambulance services, and we also participate in a number of EMS public education and prevention programs, including one very vital program that's the subject of the departmental bill before you here today. So Maryland's Public Access Automated External Defibrillator, or AED program, was first established in 1999 to expand access to emergency life-saving care for those suffering cardiac arrest. Since the program's establishment, this General Assembly has required that all public schools, county and municipal swimming pools, grocery stores, restaurants, and just last session added certain libraries to the list of entities that are required to have a registered AED on premises. In 2025, just to give you some statistics, there were 6,893 out-of-hospital cardiac arrests in the state of Maryland with an overall survivor rate of 8.4%, which is just slightly above the national average of 8.2%. In Maryland, AEDs are applied by bystanders during a cardiac arrest event 12.1% of the time. But here's the real salient point here. When a cardiac arrest in Maryland is witnessed by a bystander who performs CPR and or applies an AED, the survival rate jumps to 34.4%, which is approximately 5% higher than the national average. And so it's easy to see how this program plays a critical role in our state's overall public health strategy. Today, just to give you some more data points, there are more than 17,250 AEDs registered in Maryland through the Public Access AED Registry, which is maintained by MIMS. What House Bill 276 does is it seeks to revise and actually streamline certain statutory provisions pertaining to the program. The use and the best practices associated with AEDs have evolved quite a bit over the last 25 plus years. And while the bill is largely technical, it also is going to ensure that the law is in line with best practice and that the statute's actually easier to understand. More specifically, this bill eliminates obsolete provisions, references to quote-unquote regional council AED committees and the like. It adds an exemption to the list of entities that can operate an AED without a valid certificate, namely law enforcement agencies that deploy AEDs in their patrol vehicles. It defines in statute the role of the AED coordinator. It adds a provision requiring the AED coordinator to promote awareness about the AED, its location and operation among potential or foreseeable operators in case of emergency. It includes grocery stores and restaurants in the definition of quote-unquote entities, since they register as such in the state's AED registry, and by doing so, that would harmonize state law with current practice, and it also makes other technical and clarifying changes. Finally, it's the goal of this legislation to streamline the review of the AED usage reports by codifying a centralized system of review by MIMS staff. So basically, every time an AED is used in the field, no matter what jurisdiction, MIMS HQ would basically be evaluating and reviewing that report. And I did want to bring to your attention that there was an amendment before you, which we also support. We did not have this amendment technically in hand when submitting our written testimony 2 days ago, but we did work collaboratively on the amendment language with both the Restaurant Association of Maryland and Maryland Retailers Alliance, two of the stakeholders. Since their inclusion in the registry pursuant to legislation adopted by the General Assembly 2 years ago, restaurants and grocery stores have been exempt from several of the program requirements imposed on other registered entities. Basically, the amendment just makes it clear that should this bill be adopted, that no additional requirements would be placed on those restaurants and grocery stores. And so again, we consider that to be a technical as well as a friendly amendment. And so with that, MIMS respectfully urges a favorable report on HB 276 as we continue to refine and enhance this emergency life-saving program. And I thank you again for the opportunity to be here.
Thank you for your testimony. Do I have any questions from the members? All right. Delegate Hill.
Good to see you, Delegate.
I'm sort of sitting where you used to sit.
I know everyone who was on the committee when I was here was on that, is now on this side of the room, except for, well, Sandy's still there and Bonnie's still there, so good to see you all.
Quick question. I like what the bill's doing. Entities that are not required, so a church, organization, they still have to comply with all of these things, and are they affected? Do they have to have a coordinator and all that if they just decide I want to have an AED? Are they penalized if they get one and they don't go through this?
No. So yeah, so we kind of did a 50-state survey, and every state does it differently in terms of which entities are required to have one. So a church, for example, which is not required to have an AED device, could have one, but they would not be required to register it as part of the public access AED program.
Thank you.
But we would certainly welcome if a church wanted to have it and have an AED coordinator that would be, spooled up on the usage as well as the FDA maintenance requirements for the device.
Thank you, Madam Chair.
Thanks.
Seeing no further questions, this concludes your testimony and also the bill hearing on House Bill 276. Thank you very much.
Thank you all so much.
We are now going to move to House Bill 279. This is Correctional Services Medication Review Committee, Administration of Psychotropic Medication to an Incarcerated Individual. If you want to go ahead and bring your panel, I believe it is you, and you can go ahead and get started whenever you're ready. Thank you.
They put 2 minutes on us.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. My name is Dr. Linda Beneski. I am a licensed clinical psychologist and the Director of Mental Health for the DPSCS. I have been with the DPSCS for 25 years, working both as a clinician and an administrator in state correctional facilities. I am here to strongly advocate for House Bill 279, which seeks to establish a medication review committee within DPSCS to address the patients who refuse to take medications in our licensed mental health infirmaries. The establishment of the review committee mirrors the same process that is already established within Healthcare General 10708, refusal of medication and clinical review panel. We have a 45-year-old patient diagnosed with schizophrenia, serving 33 years, and was housed in our mental health infirmary. He had uncontrolled hypertension and diabetes, stood for hours at his time in his cell, causing severe swelling in his legs. Despite encouragement by medical and psychiatric staff to sit and elevate his legs, he was too thought disordered to follow these directions and refused all medical and psychiatric medications and care. In June 2025, this patient suffered a near fatal stroke that left him paralyzed on the left side. He is now bedridden in our medical infirmary and requires total care. This is one example of what does occur when patients refuse psychotropic medications. Left unmedicated, these patients are often paranoid. They refuse to leave their cell or attend any treatment offered on the unit. They often deny having any medical conditions. Thus, both the medical and mental health deterioration continues throughout their incarceration. As indicated in the bill, the department has taken great care to ensure that due process rights of our patients are protected by adding language that allows the patient to appeal to the Office of Administrative Hearings. We are also proposing adding an amendment allowing the right to legal counsel should the patient appeal the decision to the Medication Review Committee. We urge the committee to vote favorably on House Bills 279, and thank you for this opportunity to speak, and we are happy to address any questions you may have.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. My name is Dr. Bevan Merles. I'm Deputy Director of Mental Health for DPSCS. I'm a licensed clinical psychologist who has worked with the state of Maryland for over 15 years, 8 of which was spent working at MDH's Spring Grove Hospital Center, and the past 7 I have been with DPSCS. I'm here to strongly advocate for House Bill 279 and to address concerns raised by those who oppose this bill. First, I want to be clear. The process outlined in this bill will only be enacted in our 2 licensed mental health infirmaries within Maryland Department of Corrections. These infirmaries are licensed and regulated by the Maryland Department of Health Office of Healthcare Quality under COMAR 1017-12. Each unit within the infirmary has been staffed to include a psychiatric provider, which is a psychiatrist and/or a nurse practitioner, who is on site 7 days per week, 6 licensed nursing professionals per shift. We have 3 shifts. Licensed professional counselors, activity therapists, and mental health technicians all working together in a collaborative, multidisciplinary approach to treat our patients. In addition, a chief psychiatrist oversees all the units and ensures on-call psychiatry services are available 24/7. Opposing testimony believes that the patients who refuse to take their medication should be admitted to a hospital for treatment. Psychiatric wards in community hospitals will not admit our patients, as DPSCS armed officers are not allowed on locked psychiatric units in the community. State psychiatric facilities have a long wait list, and DPSCS patients can only be admitted to the maximum security hospital, which is consistently running at capacity. It has been stated that DPSCS has an insufficient ability to monitor our patients, including the potential side effects and adverse reactions from medications. I'm here to tell you that all psychiatric and psychotropic medications that are prescribed by licensed psychiatrists and/or psychiatric nurse practitioners are seeing these patients daily in the mental health infirmaries. These are the same medications that are available in the community and state psychiatric hospitals and are administered by licensed nurses who monitor the patients after administration. I urge a favorable report on this bill to help us provide the same care you and your loved ones receive in the community behind the walls. Thank you for allowing me to testify.
All right, I have a question from Delegate Kaufman, followed by Delegate Alston, followed by Hill, followed by Hutchinson.
Thank you, Madam Chair. Self-determination is important. So my question is, how quickly do you envision pulling the trigger and forcing somebody to take a medication? Is it after 1 refusal? Is it after 8? I mean, I'm just asking because, you know, I feel differently about the bill if it was 1 refusal versus 8 kind of thing like that. So how many refusals will it take until you force?
Delegate Kaufman, if I can rephrase just a bit.
Yeah.
Can you speak to the standard of care for when, at what point administration would occur?
Yes, exactly, because I just was curious.
Thank you for that question, Delegate Kaufman. It's good to see you again. To answer your question, I will have to say there's a lot of clinical discretion that goes into making clinical decisions about whether or not to medicate somebody against their will. What I will say is that it's not something that is a one-time thing when we're looking at a non-emergency situation. If it's an emergent situation where somebody is physically harming themselves or somebody else, that's a different situation, and that would require a one-time refusal to take medications that would be used. However, we would have to look at the entire situation for the patient and their case, depending upon whether or not how long they've been refusing. Do they have medical complications that they are not willing to understand or agree to medication for somatic issues on top of it? So it's not necessarily a one and done. It's also not an 8-number refusal. It would be more of a clinical discretion based off of what the situation is with the patient.
Thank you.
Of course, Delegate Alston, followed by Hill.
Thank you, Madam Chair. Whatever work group this ends up in, I'd like to be on it. I just want to state that this bill has a lot of problems, constitutional ones, and I am very concerned about forcing medication on people who, if they're in their, even if they're in a psychotic state, have the ability to refuse. We can't then force them to take medication against their will without giving them due process, and I don't see that in this bill. So I don't know what due process rights do you plan to give these individuals who are already being deprived of various rights, but they still have that right, even though they're incarcerated. So what is your plan to ensure that they have adequate due process protections?
So what I would say is that they have the right to appeal to an administrative law judge. And we mirrored this process that's done in hospitals and state hospitals. And we are wanting to put the amendment in to have legal representation on that appeal. And so if they request the appeal, then the decision of the committee is stayed.
I'm going to stick with my one best question and wait for this to go wherever it's going.
And this will be in subcommittee. I'm going to take a little bit of latitude and give you a moment to just speak to the process that you have had in place in discussing this with the Office of the Public Defender, who will be here. They're also testifying in a later panel, but I know that those have been some ongoing discussions. So if you would like to speak to some of that work briefly, so that we understand that this is not the first time that
Sure.
those discussions are happening.
Thank you, Madam Chair. Yes, we have been working with the Office of the Public Defender for the past year and a half regarding this bill. We first put this bill forth in prior sessions, and we worked with them at that time as well. But we have had numerous conversations with them about the language, the process, making sure that there is legal right to counsel, and trying to mirror the MDH process as much as possible, and making sure that we're not violating any more of their concerns.
Thank you. Delegate Hill.
Thank you. So I have some concerns as well, and I hope you can help. I'm going to list some of the things that give me concerns. Number one, I'm looking for something in here that addresses the reasons for a patient saying no, i.e. the medication is not the one I was on before, I'm having side effects, or I've heard from several incarcerated individuals, not necessarily in the behavioral health unit, that oftentimes when they ask the nurse who is administering the medication, what are you giving me? They don't get a response, or they're told it's your medicine, or they won't be told the dose. If they're offered a dose or they don't recognize the medication, decide not to take it, and they put it up so that you can see on the film that they're not taking it, it's still put down as a denial or refusal to take the medication. So I don't see in here where we're looking at why they're refusing. I don't see in here, you said that all the medications are available, but my understanding is that oftentimes what's available in the facility on the formulary is different from what people have been on the outside. So that's sort of the basic piece. And we've set up this ALT program, which is having a slow rollout, but it almost sounds like you're trying to set up an ALT program within the facility because you're saying these people need this medication and somebody ought to order them to take it. And I'm wondering if that might be where we really ought to be talking about, is putting them under a structure where their reasons can be taken into account, not simply that they're not following. And oftentimes as the treating physician, you can label somebody as being unresponsive, and that label itself is you're saying it's because they don't understand their situation, they're depressed, they're whatever, and their refusal gets fed back into the loop of it's your disease that's causing you to refuse, therefore we're going to treat your disease and we won't respect your refusal. So that was a lot. Maybe you can help me.
Yeah. So I would look at DPSCS as inpatient and outpatient. And what you're talking about is our outpatient medications that are given in general population in a facility. This is a licensed mental health unit. And the patients that come to this licensed mental health unit cannot function in general population. They are not coming out of their cells. They're not showering. They're not even walking up to take their meds. They're refusing medical care. They're refusing to go see the psychiatrist. So they get admitted to our mental health infirmary. And we have non-formulary medication and formulary medication, and that is through an approval process. We have the same medications as in the community, but there's a difference that is what's going to be prescribed in a mental health unit versus an outpatient, which could be more abusive. So the patients that are in our mental health infirmaries are languishing. They don't take care of themselves. They won't come out and take showers. So part of being psychotic or having a disease state, they don't recognize that they're mentally ill. And so I know the perception is that we're going to medicate everybody, and that is not what the goal is. The goal is to prevent a 45-year-old who didn't think he had hypertension, didn't think he had other medical conditions, and didn't think he was schizophrenic, not take his meds and have a stroke. And in fact, this person was paneled at a state hospital, but came to us and immediately stopped his meds, which was his right. But now I have this man who is bedridden, and his twin sister is, our hands are tied. And
yeah. So to also answer your question, we have multidisciplinary treatment teams where we bring the patients down. We have their psychiatrists, all of the nurses that work with them, their clinical counselor that's appropriate with them, as well as the clinical director that we have there. Every single person is in that room, and they're trying to get them to take medication. They're trying to get them to engage in some sort of treatment. Honestly, we don't want to have somebody languishing, in their cell. We want them out. We want them doing groups. And a lot of these individuals, we can't even get them to do that simply because they're not stable enough to be able to participate. So it is only in the infirmary, and the infirmary is a different environment than the outpatient. And as Dr. Badesky said, there are medications that are considered non-formulary, and you're right, there are a lot of medications, particularly, I'll name one, Seroquel, that we do not like to prescribe because it is highly abusive behind the walls. However, we're able to do that in an infirmary setting because it is a much more restricted setting in terms of the nurses passing out the meds, doing mouth checks, things of that nature, as opposed to somebody having a prescription that is in their cell by themselves.
So may I follow up? Thank you. So are you saying that you are asking for the same authority that a non-incarcerated person on a locked unit with severe psychosis or other psychiatric disorder that had them non-functioning would have, or are you asking for greater authority?
No, we're asking for that exact authority, the exact same authority that is done in Health General 10708, just under the auspices of Division of Correction.
And when they begin to take their medication and improve, do they get transferred out of the unit, or does this authority to keep them on medication continue? How does that work?
I think it would depend upon how well they're doing and if they're willing to continue to take their medicine voluntarily. In my 8 years at Spring Grove Hospital Center, where I was a forensic psychologist, I saw a number of clinical review panels. I sat on a number of them. A lot of times, it's just getting them to start taking their meds, and then they'll continue to take them by themselves. And then we never ended up having to repanel, the majority of them. Of course, it might be a situation where they have to roll back through to get, back on it if they do decompensate and stop taking them. But the whole goal is to not only treat them, but to hopefully get them back out to GP. That's our ultimate goal, because our infirmaries are just as full as MDH's facilities. And we're constantly moving people as much as we can.
Thank you, Madam.
Delegate Kipke, did you have a question?
Thank you, Madam Chairman. Are you aware that the state has a mental health advance directive? And have you evaluated whether or not it can be utilized for individuals who have this, I don't know if it's a regular occurrence, or I'm sure, I believe it probably likely is, but when they're stabilized, they can sign off on you doing this in the future? Have you analyzed that?
So
We haven't. Go ahead.
So that's almost like a surrogate decision maker. You have an advance directive, they can direct what they want, medications and stuff like that. Our population is forensic, right? And a lot of them that we are serving have gone through state hospital restoration to competency. So most of them homeless, may not have family and things like that. So to be honest with you, we have not explored that.
It might be worth it. The individual signs it for the future, for themselves, for the future when they I guess you could use the word relapse, or they stop taking the medication that provides them stability. So I just bring it up as something to look at, and I want to thank you for the important and difficult work that you do for the state of Maryland.
Thank you.
All right, I'm seeing no other questions from the members, so I have a couple of questions because I was privy to the meeting between the department and the Office of the Public Defender the other day, and I had some questions that I raised in that meeting that I didn't hear in the testimony, and perhaps I missed it. But you did speak to, what is the potential outcome for not medicating, and so thank you for that. But I didn't hear, I had asked, what is the oversight mechanism for a non-hospital setting? And there was a question about whether we could add some statutory language around codifying those best practices or best practices in terms of restraint processes. And also, if your vendor has similar implicit bias training to our other health occupations. So if you could just address those questions for us, thank you.
Sure, Madam Chair. To begin, in regards to, Dr. Badesky will speak on the restraint. What I can say is that our vendor does have individuals here today to testify, so they'll be able to address that. But what I can say is that, yes, we have training that both the state employees as well as the vendor have to complete, and that's in our contract with them. And the correctional officers also have to take certain trainings that occur. They have to do that yearly. So that was to answer the first part. The other piece, I'm actually going to let Dr. Vanessa talk about the restraints first, and then come back to the last piece.
So the restraints, we don't restrain them. We hold them and we escort them out of the cell. They're not extracted. It's not a violent thing. We bring them out. The nursing staff is there. They'll administer the shot, just very similar to a state hospital. In fact, Dr. Merles was telling me today that she was a patient at Spring Grove that got restrained.
Well,
so it's
not an
practice.
actual patient, but I volunteered to be the person that was restrained.
But I mean, and I guess what I would say, that didn't come out right. So, but I know the perception of corrections. I know that testimony is like we're punitive and things like that. But our patients in this medical and mental health infirmary, like this gentleman who had the stroke really bothers me because this could have prevented. Mm-hmm. The other issue is these people, they go unmedicated for 5 years, and then we have to find a release plan. And maybe AOT would help with that. But what we're doing is we're either certifying to a state hospital or emergency petitioning them to because they can't go anywhere. So that's the outcome of being unmedicated for years in our system.
Mm-hmm. And in terms of the regulatory piece, I did speak in my testimony about the Office of Healthcare Quality through MDH. They are the ones that are surveying us. They maintain our license in those licensed infirmaries. So they do surveys yearly, spot checks. They just show up and come and look at all of our paperwork, our policies, and make sure that everything is going according to the licensing guidelines under COMAR.
Thank you very much. That's very helpful. Seeing no further questions from the committee, we have a favorable panel and a favorable with amendments and an unfavorable and a favorable virtual. So we're going to start with our favorable panel, which is Oladipo Kale. Are you here?
I would just like to thank the committee for hearing this.
Yes, thank you.
Thank you very much. Thank you for your testimony. And thank you for your hard work. I know that these are complicated issues, and we will give them the time that we need to understand them.
Thank you. Madam Chair and members of the committee, my name is Dr. Oludolapo Kale. I'm a board-certified psychiatrist and have worked in correctional psychiatry for more than 25 years, first in Pennsylvania and now in Maryland, and I currently serve as the statewide director of psychiatry for Centurion Health. I'm here today on behalf of Maryland, DPSCS, and Centurion Health to express strong and unequivocal support for House Bill 279. First, medication review panels are the standard of care. They're the standard of care across the United States. In every community-based setting, individuals with serious mental illness are entitled to due process, independent clinical review, and procedural safeguards when decisions about psychotropic medications are made. Yet in Maryland, incarcerated individuals with serious mental illness do not have access to the same standard of care. As a result, they receive a lower level of medical treatment solely because they're incarcerated. This disparity is morally unacceptable and raises serious concerns under the 8th Amendment, the Americans with Disabilities Act, and the Rehabilitation Act. Second, untreated serious mental illness like schizophrenia carry a significant risk of progressive brain damage and long-term cognitive decline. This is well-documented clinical reality. House Bill 279 creates a mechanism for independent external review to determine whether psychotropic medications may be clinically appropriate for individuals who are otherwise at risk of irreversible neurological harm. Finally, I offer a simple question. If you were unable to make rational decisions because of a severe mental illness, would you want to be left to languish in a psychotic state, experiencing preventable brain damage and cognitive decline? Or would you want access to an independent, medically informed committee empowered to review your case and identify treatment options that could preserve your health, dignity, and future? For these reasons, I respectfully and strongly urge a favorable report on House Bill 279. Thank you.
Thank you very much for your testimony. Looking for any questions from the committee. Seeing none, we're going to go to, we do have one witness who is favorable virtual. Stephen is not in the waiting room? Okay. Let the record show that we did call for Mr. Israel. He was not available in the waiting room. Thank you very much for your testimony. We're now going to go to a favorable with amendments panel, which is Evelyn Burton. Welcome back, Ms. Burton.
Thank you. Thank you very much, Madam Chair. Hello, I'm Evelyn Burton, the Volunteer Maryland Advocacy Chair for Schizophrenia and Psychosis Action Alliance. We support medication over objection in prisons to provide timely treatment to prevent harm to self or others, suffering, and the permanent brain damage from untreated psychosis. As of 2014, 44 states allowed medication over objection for prison inmates. 31 of them use administrative hearings, while 13 use judicial hearings. It's inhumane to confine inmates and allow them to suffer when their illness prevents recognition of their need for treatment. The result is excessive use of restricted housing, suicides, harm to self, other inmates, and staff, when untreated inmates are unable to follow directions. Hospital medication over objection is preferable. However, the Maryland Department of Health just about never currently agrees to hospital admission for prison inmates. By statute, they are not required to do so. State law allows monetary fines against the Department of Health if court-ordered jail inmates are not admitted to the state hospital in 10 business days. Therefore, the department prioritizes admission based on avoiding monetary penalties rather than acuity of illness and danger to self or others. We therefore support HB 279 with the multiple submitted amendments to ensure that the facility, staffing, oversight, and procedures result in safe and efficacious treatment. And I'll be glad to take any questions.
Thank you very much. Great timing. Delegate Riley.
I have a question. I probably should have asked it to the first panel, but you may know the answer. If not, I'll follow up. So when the patient is going through the, so they said they had a right to go through an administrative hearing process. Do you know during that hearing, like if there's a family member, whether they approve or disapprove, do they have any say at this hearing? Do you know?
Well, I assume I mean, I don't want to speak for them, but I
Okay, so you don't know.
can
Okay.
speak for
I can follow up with them.
my knowledge of civil hearings, which is what they're modeling it after. And in general, the family member can provide input.
Okay.
But they can only speak if the presenting party asks them questions.
Okay.
So they don't necessarily have a right to unless it's in the statute.
All right, thank you very much. Appreciate it.
Okay.
Thank you. Seeing no further questions from the committee, thank you very much for your testimony. We do have one unfavorable panel. I'm just going to check one more time that we do not have a virtual witness. All right. So we're going to move to our unfavorable, which is Kimberly Watts, Lucian Parsley, Sanji Varghese, and Michelle Livshin. Whenever you're ready, you can start your testimony.
I guess I'll go first. Okay. My name is Kimber Watts. I'm an attorney with the Public Defender's Office. I am currently the chief of the Forensic Mental Health Division. In my civilian life, I'm also a member of the Behavioral Health Advisory Commission, where I serve in my capacity as a family member of someone with mental illness. We appreciate all the discussions we've had with DPSCS and their inclusion of the right to counsel in the bill. We still have some concerns. You know, as they've said, it attempts to mirror the language in the laws for the hospitals, but it doesn't quite get there. For example, in emergency situations, this bill authorizes a practitioner to order and presumably administer the medication, but doesn't define what a practitioner is. By comparison, the relevant statute, Health General 10708, requires that to be a physician. Likewise, it's on the recommendation of a practitioner that they would go to a committee which is not simpatico with 10708. Additionally, there are obvious differences between a licensed mental health infirmary in terms of code regulations and a hospital. And so those are for reasons that I know some of my panelists will discuss. But what we would say is that, as they mentioned, the Office of Health Quality Control does spot checks. We would urge this committee to hear from that office before issuing any kind of report. I think that their insight would be valuable given that they're doing spot checks on both hospitals and the licensed healthcare infirmaries. Lastly, we would say that the goals of this bill can be effectuated in different ways by taking incarcerated people to emergency rooms. Thank you.
Did you want to finish your thought?
I was going to say, I have to believe that there is a way to solve the problem of armed guards being in psychiatric units, and there has to be a way to solve the issue of the getting people to state mental hospitals.
Thank you very much.
Do the guards have to be armed when they go into the hospital? Can they disarm before going to a hospital? I don't know. But I think that there must be some better solutions, and we're happy to continue talking.
Thank you.
Good afternoon, Chair Bagnall, Vice Chair Collison. My name is Sanjeev Varghese. I am the Deputy Chief Attorney in the Mental Health Division of the Public Defender's Office. Prior to becoming an attorney and joining the Public Defender's Office, I also have a MD. I'm a physician, went to law school later in life, and my background was my doctoral research was in psychiatry. So this is something close and dear to me. The forced medications that happen in a hospital setting are vastly different than that would happen within a penal setting. In a hospital setting, the individuals are checked every 15 minutes as a standard. That is not the same type of regulations that would be there for example, at Patuxent or elsewhere. The reason for those checks is to make sure that no adverse outcomes are coming from medication administration, as well as individuals who are psychiatrically decompensating and suffering from the burden of their symptoms, that they are doing well and not harming themselves or others, and not presenting as that danger. The forced psychotropic administration of psychotropic medications causes potential lethal side effects. You could have neuroleptic malignant syndrome, which is potentially fatal. You could have less severe side effects like dry mouth or excess salivation. But you also could have sexual dysfunction. You could have gynecomastia, where men actually develop breasts and can actually start lactating, galactorrhea. These are all significant side effects that are there within these medications. And these medications are best administered in a hospital setting. Currently, if an individual's in the community even, receiving 24/7 level care at a RRP, residential rehabilitation program, or other psychiatric program, they can't be forcibly medicated there, despite those staff all being licensed clinicians, because it is not the hospital setting. We are willing to continue working with the department on this bill, but we do oppose it in this current form. Thank you.
Thank you, Chair Bagnall, Vice Chair Collison, and committee members. I'm Michelle Lifshin, and I'm here representing Honor Own of Maryland. We're a nonprofit, peer, statewide education and advocacy organization representing 10,000 people with mental health and substance use recovery conditions. Honor Own of Maryland is opposed to HB 279, which would permit the administration of psychotropic medications to incarcerated individuals with a serious mental illness against their will. Psychotropic medications can cause very serious and sometimes debilitating side effects. And so it's necessary that individuals have qualified mental health professionals, timely examinations, and appropriate treatment services must be adequately provided. Unfortunately, a 2024 audit by DLS regarding DPSCS compliance with healthcare and mental health service delivery contract requirements found inadequate staffing of mental health professionals, a substantial lack of mental health examinations, and overall insufficient response to health concerns. We found in a 3-month period in 2023 that there were 682 required mental health exams and 548 required suicide risk evaluations that were not completed. And there are ongoing concerns. People should not be forcibly medicated in an environment where they're unable to access concurrent intensive treatment. While clinical review panels consult on forced medication programs in Maryland's psychiatric inpatient facilities, these institutions have 24/7, 365-day emergency response capabilities in the event of adverse medical effects by the virtue of being a healthcare facility. Incarcerated individuals deserve to be evaluated by qualified professionals and provided urgent treatment when experiencing a behavioral health crisis. We urge an unfavorable report. Thank you. Oh, let me just.
Good afternoon. I'm Lucienne Parsley, Disability Rights Maryland. We're the Protection and Advocacy Center for People with Disabilities for the state of Maryland. Over the past decade, Disability Rights Maryland has investigated mental health care provided to people in our correctional facilities, finding the care seriously inadequate, particularly for those housed on the segregation and inpatient mental health units. We have visited, toured many of the facilities, have reviewed thousands of pages of medical records, and engaged with the Department of Public Safety and Corrections. We've found that the health care provided to many people with mental illness is constitutionally deficient. We do appreciate the attempt to improve care. The first thing I would like to say is that we appreciate the department's saying that they are going to provide an amendment to provide for the right to counsel. Right to counsel is not provision of counsel. People cannot afford an attorney. They will not be able to take advantage of that. In the state hospitals, an attorney is provided for them. Under 10708, people have the right to contest before an administrative law judge. That would not be possible under this. The Mercer decision from the Maryland Supreme Court provides that people who are in state psychiatric facilities have the right to counsel, and we think that that should be provided for these individuals as well. Secondly, OHCQ does not do spot checks. I did go to OHCQ and do a PIA request, and I appended to my testimony the 3 licenses for the correctional mental health facilities that are licensed. OHCQ only licenses them. They do not come in and monitor. They do not investigate any perceived complaints that they receive. I would urge you to go see the inpatient mental health unit at, for example, Maryland Correctional Institution for Women. It is stark. Women are in their facilities, in their cells 24/7. They are often there without any clothes. They do not receive much mental health care at all. I've had communications with the department at times.
Please wrap up your thoughts. Thank you.
Thank you.
Delegate Kaufman. Oh, sorry. Wait. No. Delegate Kaufman followed by Delegate Riley.
I understand your position, but at the same time, I'm deeply troubled about the man that got a stroke as a result of not taking his medications. And so while I don't love the idea of forcing people to get medications, I don't want them to develop a co-occurring condition that worsens their condition. So my question is, what if you don't like forced medication, what is your alternative, especially given that the beginning panel said hospitals are reluctant to treat the inmates when they come to an emergency room. And so what's your alternative so people aren't getting strokes for not taking their medications?
Thank you, Delegate Kaufman. So currently, individuals who are at Patuxent or other facilities can be sent to a state hospital for treatment. That is already provided for by statute. Recently, I had a client who was at Patuxent, was ready to be released. And on the day that he was to be released, he was certified and sent to Spring Grove. That was taking a bed that should have been there for individuals who are IST or NCR who are on that wait list. That individual was actually released before a hearing. But to the forced medication issue, that can happen in the hospital setting. And where those due process rights are afforded, as well as, just as importantly, the medical oversight for that therapeutic intervention and continued treatment. As Dr. Merles testified to earlier, when she was at Spring Grove, she was involved in numerous forced medication panels and hearings. And she said that after they start, as she testified, she said that after they've been taking it, they often continued with those medications after the forced medication panel had ended. So if individuals were sent to a state psychiatric hospital, received that treatment under the forced medication if it was found to be warranted, they could then go back to the department in the prison setting, and if their prison setting is able to provide them with those same formularies and same medications, they could continue on those medications, which the testimony was earlier that they generally willingly accept.
Thank you. Delegate Riley.
Thank you, Madam Chair. The good delegate just had my question answered. Thank you.
Delegate Alston.
Thank you, Madam Chair. I guess this can go to either person from the Public Defender's Office, maybe Mr. Sanjay. Do you believe it is legally, morally, or ethically correct, either as your experience as a doctor or as an attorney, to give a person who is not mentally stable notice of an appeal and tell them that they have a right to appeal a decision when they probably don't even understand the paperwork that they're being given? And then you're doing it without them having access to counsel, and you're doing it in a setting where they really don't have rights. What are your thoughts on that?
In medicine, as well as in law, you're meeting the individual where they are. When you're explaining the legal process to an individual, you're meeting them where they are and with whatever they're able to take away from that conversation. And if they don't understand all the rights at that first conversation, I have follow-up conversations with my clients. It takes time to develop that relationship of trust. Medically, in the medical field, again, you have to meet the client and explain the terms in a way for that patient that they can provide informed consent. And I do not believe that the forced medication, as it's being sought to happen in these correctional facilities, is ethically or morally correct for these individuals who are already suffering from illnesses.
Thank you.
Delegate Hill.
Thank you, Madam Chair. I was always told that to have a person who's in psychiatric distress and deny them medication is like taking a patient who's having severe pain and denying them pain medication. And I want to be clear, so I'm going to do this by a show of hands. I think, Doctor, that your main thing was they don't have the proper staffing to monitor the potential outcomes. You also mentioned side effects, but those side effects don't matter whether they're getting the medication in that facility or somewhere else, right? The side effects are the side effects, right? So by a show of hands, how many of you would still object to the forced medication on these psychiatrically impaired people who have been refusing medication if they were in a psychiatric hospital setting with 24-hour on-site psychiatrist presence? And how many would you still oppose it in that different setting? That's just your baseline, that you should never force a medication?
Assuming they're going to get due process. Like
Say again?
Assuming they would get the due process rights that
So same patient, one's in the correctional infirmary, second situation, they're in the psychiatric hospital. Would you still oppose the prescribing or the forced giving of the prescribed medication? Anybody would oppose it in that situation?
So for me, we all have different value systems, and I recognize that my clients have different value systems that may not be my own. And so I advocate for my client's stated interest, and that's my role within that position. So if my client is advocating, saying that they don't want to take a medication, I would utilize the legal system, as my role is, to advocate for them not to be forcibly medicated in that setting.
Right, so for you, it's not a matter of the location.
Delegate
For the
Hill.
other three, it is.
Delegate
Okay,
Hill.
thank you. All right.
I'm aware we have 6 more bills today, and I have some questions too. Just looking to see if we have any other questions. I am concerned by what I'm hearing, because I think, to Delegate Hill's point, there is a question of whether we continue to move the goalposts. As we heard before, this is a bill that we've had in the General Assembly for a number of years. It's new to our committee, but it's not new to us. And we know that we have concerns about oversight. We have concerns about people languishing in these facilities. And I heard testimony about gynecomastia and dry mouth, which are not emergent issues that require a hospital setting. Psychotropic medication administering is not required in a hospital setting. In fact, that often happens well outside of a hospital setting. And I think we did hear comments to the effect that in a hospital setting, it would require 2 armed guards accompanying that patient to the hospital for administering of medication and then transfer out of the hospital setting. So my question is it the position of this panel, whoever is best to answer, that in these situations, psychotropic medications are, the administration, without consent, is never appropriate outside of a psychiatric hospital?
I would say no. We feel that when due process is provided to people and they have the right to be represented and to have those protections, that the system under 10708 works well. That doesn't seem to be the same protections that are being provided through this bill.
So you're looking for further protections, not necessarily that it not occur in a mental health infirmary?
Ideally, people would go to the hospitals. That does not seem to be the option right now. We agree that some people are languishing. I've also had conversations on behalf of my clients where the department says this person's not going to get any other mental health treatment, supportive therapy groups, until they start taking their medication. That is, we think, morally wrong. If people are languishing and they get all the due process protections and there is adequate staffing and other services available to people in the correctional mental health centers, the inpatient mental health units, I think that we would be amenable to that.
Thank you. I'm going to strongly suggest we continue these conversations. I think you've heard volunteers from this committee willing and able to convene those conversations, and I hope that we will be able to move forward so that we are not just, providing a high standard of care for our incarcerated communities with mental health, severe and persistent mental health issues, but also that we are codifying those best practices so that we're not looking at the same challenges in a future administration. Seeing no further questions, this concludes your testimony and the hearing on House Bill 279. We're going to move to House Bill 42. If I can ask my panel to come to the table. And for the committee, I'm going to take my testimony from here because I hurt myself today and it's hurting to walk back and forth. So I hope that you will give me the grace on that. All right. Good afternoon, Madam Vice Chair, and to the honorable members of the best committee in the General Assembly, the Health Committee. For the record, I'm Delegate Heather Bagnall, District 33C in Anne Arundel County, here in strong support of this pre-filed House Bill 42, State Board of Massage Therapy Examiners revisions. You have my written testimony, so I will quickly summarize. House Bill 42 is a simple technical revision to the massage therapy registration and licensure processes. In 2022, House Bill 220 established a framework for licensure of massage therapy under a health occupations board, phasing out the existing massage therapy registration, and it also sunset the registration process September 30th, 2026, at which point any practicing massage therapist that has not yet received licensure will be required to apply for it. Now, House Bill 42 adds language allowing those with current unexpired registrations, those that were granted before the initial implementation date in 2023, to retain their registration for the remainder of that period, at which time they will need to apply for a full licensure if they wish to continue. Additionally, the bill clarifies requirements for licensure for applicants who completed educational and training programs outside of Maryland, and it allows the licensure board to issue a fine in the event the licensee does not update the board within 60 days of a change in their name or address without a disciplinary hearing. House Bill 42 will make the transition to full licensure seamless and cost-effective, and for these reasons, I ask for a favorable report. I will also mention the fiscal note. You will see that it says potential meaningful for small businesses, which gave me a little bit of heart palpitation when I first saw it, but I realized it's actually in savings for those businesses, not in expenditures, because they'll be able to continue with their registration to the full date before they have to renew. With that, I will turn it over to my panel and say thank you very much.
Okay. Good afternoon, Madam Chair and members of the Health Committee. My name is Stephen Conti, licensed massage therapist and chair of the Maryland Board of Massage Therapy Examiners. I'm here before you to outline the board's support for House Bill 42 and request a favorable vote from this committee. House Bill 42, in short, seeks to repeal statutory provisions that limit registered massage practitioners, or RMPs, from practicing in the state. It removes obsolete language from our statute and updates requirements for licensees returning from inactive status. In 2023, the Maryland General Assembly enacted legislation prohibiting the board from issuing initial registrations to RMPs after September 30, 2024. Not all RMPs met the statutory requirements to convert to the licensed massage therapist, or LMT status. Allowing certain statutory provisions to remain in place would prevent more than 1,100 currently registered practitioners from continuing to practice after October 31st, 2026. This outcome would unnecessarily disrupt the massage therapy workforce and significantly reduce public access to care. Repealing these provisions ensures continuity of services while maintaining appropriate regulatory oversight. Since the board is no longer able to issue RMP registrations, the bill also removes obsolete provisions that serve no regulatory purpose. The bill also clarifies that licensees and registrants who have remained inactive or non-renewed status for more than 5 years must meet the qualifications for licensure as an LMT at the time they seek to return to practice. This clarification is particularly important for RMPs, as the board no longer has the statutory authority to issue initial registrations. The provision ensures consistent application of current licensure standards while protecting public health and safety. For these reasons, we are seeking a favorable report on House Bill 42, and thank you, Delegate Bagnall, for sponsoring this bill.
Good afternoon, Chair Bagnall and members of the Health Committee. My name is Sabrina Lopez. I'm the Vice Chair of the Maryland State Board of Massage Therapy Examiners. And I'm here today to request a favorable report on House Bill 42. This bill introduces critical reforms to the licensure of massage therapy, prioritizing public safety, professional accountability, and administrative efficiency. By closing existing regulatory gaps, this bill ensures that the facade of legitimate practice cannot be used to mask illicit activity. The board supports establishing a clear and transparent licensure pathway for applicants educated outside of Maryland. This bill ensures that the graduates of out-of-state massage therapy programs meet the same educational standard required of in-state graduates. Given the national proliferation of diploma mills, this provision closes a potential loophole that could otherwise allow inadequately trained individuals to obtain licensure. Strengthening these requirements protects consumers and maintains the integrity of the profession. This bill also authorizes the board to require a state and national criminal history background check when a license or registration is reactivated after 5 years or more in inactive or non-renewed status. When criminal background check requirements became effective October 1st, 2016, they were not retroactive and did not apply to individuals who were already licensed or registered at that time. Currently, 206 inactive licensees and registrants were credentialed prior to the enactment of this requirement. If these individuals return to active practice, this provision ensures a comprehensive background review and supports the implementation of the FBI's Wrap Back program for massage professionals. Also, under the current law, the board is required to hold an administrative hearing before imposing a civil penalty for minor violations, such as failing to notify the board of a name or address change within 60 days. The cost of conducting such hearings often exceeds the maximum allowable penalty of $100. Eliminating the hearing requirement for minor non-disciplinary violations reduces unnecessary administrative burden, conserves state resources, and spares licensees and registrants from undue stress and expense while still allowing the board to enforce compliance. This bill is about consistency, transparency, and safety. It protects the integrity of the profession, ensures our background check system is comprehensive, and allows the board to steward state resources efficiently. I respectfully urge a favorable report, and thank you, Delegate Bagnall, for sponsoring House Bill 42.
I expected all hands to go. Seeing none, thank you very much for your testimony. Thank you. And I believe this concludes the hearing on House Bill 42. Thank you very much.
Thank you, Madam Chair. Thank you, committee.
Thank you very much. Thank you, Madam Chair, Vice Chair. We are now moving to House Bill 158. This is Maryland Medical Assistance Program, Maternal Health Monitoring Pilot Program. We're welcoming back Delegate Woods to our committee. Delegate Woods, if you'd like to bring your panel and get started whenever you're ready.
I guess I can wave at everybody while she's talking. Hey, everybody, I miss you. So good to see you.
Delegate Woods, you can get started.
Good afternoon, everyone. As you know, my beloved previous committee, I'm Delegate Jamila Woods. I did not say yesterday, Chair Bagnall, how good it is to see you sitting in your position and to formally congratulate you in front of everybody. So I wanted to do that now. And to my esteemed previous members of the Health Committee, I miss you guys, and it's always wonderful to see you. For everyone else, I'm Delegate Jamila Woods, and I'm here today to request a favorable report on House Bill 158. This is legislation establishing the Maternal Health Monitoring Pilot Program within the Maryland Medical Assistance Program. As policymakers, we have a responsibility to address preventable maternal health complications with solutions that are proactive, evidence-based, and centered on patient safety. HB 158 responds directly to that responsibility by supporting pregnant and postpartum Medicaid recipients who face higher risks due to maternal hypertension and maternal diabetes, two of the leading contributors to severe maternal morbidity and mortality. Maryland has taken important steps in recent years to improve maternal health outcomes, including the passage of HB 553, Maryland Medical Assistance Program Maternal Health Self-Monitored Blood Pressure Monitoring, sponsored by my dear colleague, Delegate Danny Taveras. HB 553 laid critical groundwork by recognizing the value of self-measured monitoring as a tool for early detection. HB 158 builds on that progress. It expands the scope by establishing a structured pilot program that integrates remote patient monitoring, clinical oversight, escalation pathways, and coordinated care for high-risk mothers before, during, and after pregnancy. Too often, complications related to hypertension and diabetes escalate silently between appointments. For Medicaid recipients, barriers such as transportation, limited access to specialists, and delayed follow-up care can turn manageable conditions into life-threatening emergencies. HB 158 addresses this gap by allowing health data to be securely collected and reviewed in real time, ensuring that warning signs are identified early and acted upon quickly. This approach is also fiscally responsible. We all understand that preventable complications are expensive, and those costs fall on families, providers, and the state. The average cost of a full-term delivery is often cited around $15,000, a cesarean delivery around $26,000, and preterm births can cost between $76,000 and $114,000, particularly when a NICU stay is involved. The cost of a preterm birth is not just medical, it's developmental, it's emotional, and it's long-term. Remote monitoring can generate savings in several direct ways. First, it can reduce the rate of very early and severe preterm births, particularly babies born before 32 weeks, which often leads to shorter NICU stays and fewer complications. If even a small number of NICU stays are avoided or significantly reduced, the pilot can pay for itself. Also, it can reduce the rate of macrosomia among diabetes patients, meaning fewer high birth weight babies that require cesarean delivery. Better glucose control supports safer birth weights and increases the likelihood of vaginal deliveries. Likewise, it can reduce preventable emergency room visits and strengthen postpartum follow-up through health coaching and consistent monitoring. This bill is not about replacing providers or adding unnecessary complexity. It is about strengthening the connection between patients, managed care organizations, and clinical teams. Through FDA-authorized remote monitoring technology, participants receive devices, training, and continuous support from licensed nurses, dietitians, and certified diabetes care and education specialists. Clear escalation pathways ensure that when readings indicate concern, providers are promptly engaged. The pilot program is thoughtfully designed, time-limited, and fiscally responsible. It prioritizes geographic diversity, collects comprehensive outcome data, and requires a detailed report to the General Assembly evaluating impacts on maternal outcomes, neonatal outcomes, and program costs. Most importantly, it allows Maryland to assess whether this model should be expanded statewide based on real results. HB 158 represents a practical investment in prevention. By supporting mothers during the most critical stages of pregnancy and postpartum care, we can reduce ICU admissions, emergency interventions, and preventable deaths while improving long-term outcomes for both mothers and infants. For these reasons, I respectfully urge the committee to issue a favorable report on HB 158. And if I can, I'd like to note that there are literally no unfavorable responses to this request. Thank you. Evan.
Okay. Good afternoon. Hi, Chair Bagnell and Vice Chair Cullison and members of this committee. My name is Evan Hoffman. I am the Director of State Government Affairs for a company called Philips. We are a healthcare technology company. We are very supportive of this bill. And I'm here to be a resource to talk about what remote monitoring actually looks like in practice. Philips, we no longer make light bulbs or TVs, so you're probably wondering why is Philips at this table. We have actually been a global leader in maternal and infant health technology for over 50 years. We're one of the global leaders in ultrasound, in fetal monitoring technology in the hospital. Many families across Maryland love our beloved baby products through Philip Avent, our brand. Over 23,000 Marylanders who were pregnant last year used our Pregnancy Plus app to help them have a safe and healthier pregnancy journey through a digital device. So we are very much interested in maternal health and helping women who are underserved access better care through technology. In that vein, we have moved into tele-obstetrics, both through tele-ultrasound, but also through partnering with healthcare providers and managed care plans and implementing remote patient monitoring programs for individuals who have high-risk pregnancies given their hypertension and diabetes. And so I'm here as a resource to this committee. Phillips, we have been selected as a partner with the state of Georgia in implementing a similar pilot program to support pregnant individuals who have hypertension or diabetes. Over the last 18 months, we have worked with over 450 moms who have either diabetes or hypertension in Georgia. And we are seeing some very promising trends like reducing ER visits, reducing the likelihood of having an extreme preterm birth, in addition to having healthier birth weights for women who have diabetes, their babies. The health coaching is also really important. Our health coaches partner with our members, and through that, we are able to help them, for example, be more compliant with postpartum visits that we want our high-risk pregnant mothers to go to. And so with that, I'll close. We're here as a resource, and we're very supportive of this bill. Thank you.
Thank you. Thank you. And before I take questions, I also had Ebony Venny Ford. Are they on your panel, or are they just favorable?
I don't have them on my list then.
Okay, I just wanted to double check. All right, now let me start with Delegate Gazzoni.
Thank you, Madam Speaker. Good to see you, Delegate Woods, as always. Sorry,
also.
I elevated you. I'm sorry. I don't think you want that elevation just yet. Anyhow, I am looking at the fiscal note on this, particularly the additional comments from MDH at the end with regard to having to apply for an 11.
Delegate Gazzoni, I can't hear you.
Sorry. I'll lean in a little bit more. So I'm looking at the fiscal note, and in particular, the additional comments towards the end of the fiscal note where MDH advises that you'd have to apply for an 1115 demonstration waiver, and there appears to be some concern about that, and I'm also fairly sure that that would add to the timeframes involved, so I'm just curious about that.
I honestly don't know. I can't answer that for you. I'm sorry.
Okay.
Vice Chair Cullison.
Thank you, Madam Chair. Mr. Hoffman, I actually had a Philips radio in junior high, so I know what they used to do. Thank you, Delegate Wood, for this bill. I don't know if you know, but we spent a great deal of time yesterday being very concerned about the rate of maternal and infant mortality in Maryland. So I see this as a real step towards helping towards that, because one of the things that we noted was, while we have a lot of data, we don't have programs in place that are actually making a difference. And I hear from Mr. Hoffman that the potential to make a real difference is there. So my question is actually for Mr. Hoffman because, well, let me ask my question and then I'll explain it. So in your Georgia pilot, what is the maximum amount of money per participant that is the cost of administering this program?
The Georgia Department of Health, in partnership with the Georgia Department of Community Health, is administering this program. And there are two aspects to this program. It's remote monitoring, but also home visiting as well. And so I can only speak for the remote monitoring portion, but it's in the range of $600 to $800 per mom who is in the program in Georgia for the remote monitoring.
Our fiscal note references $2,000 per participant, so I want to get a sense of what's happening on that.
Delegate White Holland, followed by Delegate Kaufman.
Thank you, Madam Chair, and thank you, Delegate, for bringing this bill. I appreciate you elevating this as a valuable intervention. Plus, I am someone who has also benefited from this. This time last year, I was enrolled in my healthcare plan's remote patient monitoring program as I had hypertension during pregnancy and also developed preeclampsia. And I had a regularly scheduled call from a nurse from the maternity care center. And whenever I had a high reading above 140/90, I got a text, there was a phone call, and I was even directed to the hospital on July 14th. And as you all know, Riley came July 16th, so there we go. And so I'm very glad that in hearing from our colleagues yesterday during our maternal health briefing, that we have some of these programs in place. And in fact, we do have remote patient monitoring that is covered by Medicaid, where patients can be directed to participate if medically needed. But given this, for our own hearing as members of the committee, can you share some of the differences between what is already in place and what this bill offers that may be different or expounds upon what we already have that is covered by Medicaid for remote patient monitoring around chronic disease conditions?
For one thing, and I'm going to ask, you may be able to help me understand this, but from what I understand, the remote patient monitoring that you are speaking of is not available to everyone. That's the number one first concern. I understand that there's a program out of Prince George's County, out of a hospital in Prince George's County that offers these types of services. But my primary concern is it does not reach all of the potential mothers who could have this challenge. And we want this bill in place so that everyone who is eligible for this program can receive this service, and not just a limited group of people, or certainly not just a group of people from one particular geographic region.
Again, Delegate, if I may, Madam Chair, I know that we've spoken about this as well.
Correct.
And so looking forward to working this on subcommittee and making sure that we bring not only, people that have testified, but even our carriers, insurance carriers, to make sure that they also have a seat at the table, since they are also mentioned in the bill. So just wanted to signal that to the committee as well. But thank you, Madam Chair.
Delegate Kaufman.
Thank you, Madam Chair. I want to give you a chance to respond to something I found interesting. First of all, as somebody who was born at 32 weeks, I love this bill. So I like the bill. But it says the department notes that the pilot mirrors benefits that are already covered under Medicaid program, and as such may not be sufficiently innovative to qualify for federal matching funds. And it says it has commonality with an initiative already underway through the postpartum maternal health collaborative. So what is your response to basically, we're already doing it? Thank you very much.
I'm sorry. Response to?
The Department of Health essentially saying that they're already doing a lot of what your bill asked for.
Sure. Again, I want to repeat what I shared with Delegate White-Holland, is that this is not available to, this service is not available to all women who would qualify for it. So that's a major concern.
And if I may add, Delegate Woods, thank you.
Is that okay?
It's one response. But I had a question. Did you have anything to add to that, to Delegate Kaufman's question?
Thank you, Madam Chair. Yes, while I'm not familiar with the current programs Maryland has in place, I can speak to the design of this pilot and what I'm seeing, and that is that it's through Maryland's managed care plans. And if you think about it, I think this is a really smart approach, and that's because in any given day, if you're just talking to one OBGYN or one MFM provider, they're only able to support their current patient base. But this pilot works through Maryland's managed care plans, and so from a scalability standpoint, they're able to look out across all of their members who potentially have these high-risk pregnancy conditions and refer members into this program. And so regardless of what's currently out there, I think this is a really smart approach from a scalability standpoint, because you'll be working through the health plans and their members across the entire state. Right, and of course, there's postpartum monitoring as well in this pilot program, which is really critical for 3 months.
Thank you so much. I'm looking. All right, seeing no further questions. No. We conclude this testimony. Thank you so much. I do have two favorables. Ebony Venny Ford. And I had Anna Rodney in virtual. Let the record show that we did call for Ebony Venny Ford and Anna Rodney, and they were not available for testimony. So I will bring up our favorable with amendments, and that is Michael Patty and Robin Elliott.
Thank you.
Good afternoon, Robin Elliott. I'm here today on behalf of the American College of Nurse Midwives, the Maryland affiliate. Very, very much in support of this bill. We know that remote patient monitoring works. We know that we have health disparities in Maryland, and this bill seeks to make some advancements, and we really have the ability to make concrete, solid improvements. We have requested of Delegate Woods, and I believe she's amenable, to change the sort of the way that the providers are described in the bill so that it would be inclusive of any provider who provides prenatal care. And with that, thank you so much.
Great, and Michael Patty here today on behalf of the Maryland Community Health System, a network of federally qualified health centers across the state of Maryland that provides somatic behavioral health care and then dental services to primarily underserved communities, obviously in strong support of the bill, with the same amendment just to broaden that healthcare provider definition. Obviously, you know, the FQHCs employ providers that may not fall under the current definition. That's why we're here today, just wanting to make sure that we can continue to provide and participate in this service if it gets a favorable report. So thank you.
Thank you very much for your testimony. Do we have any questions for these witnesses? Seeing none, this concludes your testimony and the bill hearing on House Bill 158. Thank you very much. We're going to move to House Bill 7, which is State Board of Examiners for Audiologists, Hearing Aid Dispensers, Speech Language Pathologists, and Music Therapists authority to issue limited licenses to practice music therapy. And Delegate, do you have, are your virtual witnesses, is that your panel?
Yes, virtual is my other panelist, please.
Okay, so you can get started, and we'll make sure that we've got your virtual witnesses as part of the panel.
Thank you very much. Good afternoon, everybody. Madam Chair, Madam Vice Chair, and members of the committee. For the record, my name is Delegate Pam Gazzoni, and I represent District 13 of Howard County. I'm here today in support of HB 7, which adds a limited license for music therapists to practice in Maryland while working toward their certification examination. The limited license for music therapists will function in a manner similar to the ones all of the other professions on this board enjoy. And as a reminder, the board encompasses audiologists, hearing aid dispensers, speech language therapists, and music therapists. Under current law, music therapists cannot practice in Maryland before passing the national certification exam for music therapists and earning a full license from the board. A limited license will allow qualified professionals to provide care and gain important experience while under the direction of a direct supervision of a fully licensed music therapist. By removing barriers to entry, the limited license expands the workforce and increases the accessibility to music therapy. The work experience, support from supervising practitioner, and additional time to prepare for the national certification exam strengthen the limited license holder's ability to successfully pass the examination necessary for full licensure status. Adding a limited license will create a more effective and efficient licensure process, as well as support music therapists and the important care they provide to their patients. I respectfully request a favorable report on HB 7.
Thank you very much. And we're going to go ahead and bring up your panel as well. So I have Alicia Barksdale and Dr. Kashana A. Cross. And Alicia, you can get started when you're ready.
afternoon, Madam Chairman and
Ms. Barksdale, can you get a little closer to your microphone?
Sure. Can you hear me now? Can you hear me now?
Yes, go ahead and start.
Great. Good afternoon, Madam Chair and members of the committee. My name is Dr. Elisa Barksdale. I'm representing the Board of Audiology, Hearing Aid Dispensers, Speech Language Pathologists, and Music Therapists, and I am a practicing music therapist. The board is asking for a favorable report for House Bill 7 for the authority to issue limited licenses for music therapists. The clinical training process for music therapists includes a minimum of a bachelor's degree in music therapy followed by a clinical internship culminating in 1,200 hours of supervised clinical experience before taking a national board exam through the Certification Board of Music Therapists to become board certified. Nationally, interns have been eligible for hire with the requirement of that board certification be obtained within a specified time frame. In states where a license is required to practice music therapy, this can delay their employment eligibility while preparing and passing the board certification exam. The delay in music therapists entering the field while preparing for this is increases the demand for services and affects quick access to services for vulnerable populations. The other disciplines overseen by our board already are able to apply for a limited license so that they can provide services under the supervision of a fully licensed practitioner. We are asking for consistency across the disciplines under the board. And I welcome any questions from the committee.
Thank you very much for your testimony. We still have Dr. Cross, correct? Oh, we don't, okay, let the record show that Dr. Kashine Cross is not in the virtual waiting room. So we will go ahead and open it up to questions. And I have a question from Delegate Rosenberg, followed by Delegate Hill.
Thank you, Madam Chair. I believe you just said, or the witness just said, that there are comparable limited therapy licenses dispensed or authorized for this board already. Is that correct?
That's correct.
Okay, thank you.
Delegate Hill.
Thank you. So, Ms. Secretary, just wanted to clarify, do the limited license individuals, are they able to bill independently or they can only bill under the supervisor?
They will bill under the supervisor until they have passed their board certification exam.
Okay, and it's limited for a year. Are they able to, like, for some reason they get sick and they're not able to complete their hours or something, can they extend it beyond the year or they have to start all over? What happens if for some reason they're not able to complete everything they need to do in a year?
They can reapply for a second limited license for a second year. After a period of 2 years, if they're not board certified, then they need to wait a year and reapply for a limited license again after a year.
Okay, thank you.
Mm-hmm.
Seeing no further questions, this concludes the testimony and the bill hearing on House Bill 7. Thank you very much. And we are going to move on to House Bill 196. This is Public Health Baby Food Testing Definition of Baby Food. All right, well then why don't we take a brief recess to finish the copies and we can all take a little bit of a stretch. So we'll take a 5-minute pause so that we can get the amendments and we can also stretch our legs a little bit. Thank you very much. We are back from our brief break, and we are on House Bill 196, Public Health, Baby Food Testing, Definition of Baby Food. And Delegate, you can start whenever you're ready.
Is this on? No. Thank you, Madam Chair. Now it's on. Hey. So great to be back here. Thank you, Honorable Chair Bagnall, Vice Chair Cullison, and committee colleagues. As always, it is an honor to be part of this esteemed body. I'm here to ask for your favorable report on HB 196, Public Health, Baby Food Testing, Definition of Baby Food, as amended. This bill updates the definition of baby food under current law by including infant formula and infant cereal. As a result, this expands Rudy's Law to include foods that infants regularly consume, ensuring that formulas and cereal are included under existing safety testing and QR reporting requirements. Despite studies showing that infant formula and cereals contain elevated levels of toxic heavy metals, they were excluded from original drafting of California's baby food bill, a mirror of Rudy's Law, because the industry was already heavily regulated by Food and Drug Administration. This loophole allows infant consumed products to fall outside the mandatory QR reporting requirement. The QR code is supposed to lead a consumer to a webpage where they can easily see the heavy metal test results. This eliminated the marketplace transparency parents yearned for after the persistent national scare and a decade of inaction until 2 years ago. In 2020, the Clean Label Project found that 95% of baby food had elevated traces of these heavy metals, failing to meet FDA guidelines. In 2021, a subsequent investigation found that popular brands that had levels of arsenic up to 91 times the FDA recommended levels lead up to 117 times of FDA recommended levels, cadmium up to 69 times the FDA recommended levels. So independent tests with Healthy Babies Bright Futures revealed that 95% of 168 baby foods tested with multiple popular brands contained heavy metals. In the test, 1 in 4 products contained all 3 of the most concerning metals, including arsenic, cadmium, and lead. On March 2025, Consumer Reports tested 41 types of powdered infant formula and cereals for toxic chemicals, including arsenic, lead, BPA, acrylamide, and PFAS. They looked at frequently used WIC-approved products like Enfamil and Similac, new brands like Bobby, and imported brands. What they found was shocking. About half of the tested samples contained potentially harmful levels of at least one contaminant. The data also reassured the public that there were good options in the marketplace. As recently as December 10th, 2025, FDA launched a new initiative in response to rising concerns about contaminants in baby foods, infant formulas, and cereals. In fact, if you look at just what happened last week in Florida, January 9th, 2025, they recognized that they must do better on infant formula. Given babies' low body weight, they are more likely to absorb these heavy metals. Such exposure in early childhood is linked to serious health issues, including developmental disorders such as neurocognitive impairments, growth disorders, organ and bone diseases, and cancer. For example, Rudy's exposure to elevated levels of lead have left him with lifelong health problems. You've all met Rudy. This situation is further exacerbated by the lack of federal mandates. FDA has released guidance on heavy metals in baby foods and launched a new initiative. No guidance on mercury has begun, and the initiative is reactionary and a temporary fix to a scandal. There is also a severe delay in standardization across the U.S. on these matters. Maryland, therefore, has a crucial role to play in safeguarding the health of its infants now. We cannot afford to wait on the sidelines. I humbly request your favorable recommendation on HB 196. Our children's lives are at risk. Thank you. Do you want to go in there?
Yeah, I go now. Thank you. Can you hear me? Thank you for having me. My name is Molly Hamilton. I'm the Executive Director of the Clean Label Project. Clean Label Project champions transparency and safety in consumer products by testing for hidden and harmful contaminants and empowering consumers with the data they need to make informed purchasing decisions. Our mission began nearly 10 years ago with infant formula, one of the earliest products that we studied. What we found was deeply concerning. 39 of the nationally distributed infant formulas we tested had measurable levels of lead. 5 contained lead at twice the EPA's cause for concern level in drinking water. 2 had higher concentrations of lead than what was found in the water of Flint, Michigan. In essence, we were allowing infants to ingest levels of lead that we would not permit an adult to drink in a single glass of water. Clean Label Project has carried out 3 extensive studies of the best-selling infant formulas in the U.S., performing over 30,000 tests on nearly 250 different products. We also evaluate formulas from companies that voluntarily strive for lower contaminant levels, pioneering transparency and delivering healthier options. However, much work remains. In the U.S., 54% of infant formula is consumed by children in the government-funded Women, Infant, Children WIC program. However, the WIC bidding process does not consider contaminant levels, even though they directly affect the infant's long-term health, as has been tragically demonstrated in Flint, Michigan. We are often asked what burden this testing would place on manufacturers. The question overlooks for far greater burden placed on the developing bodies if the testing is not done. We know what's achievable based on the success of Rudy's Law and baby food. The standards should be no lower for a newborn than they are for a 1-year-old. We support the expansion of this law under HB 196 to include infant formula and applaud the efforts of the state of Maryland to be the first in the country to deliver what the federal government has not.
Thank you. My name is Tom Neltner. I'm the National Director of Unleaded Kids, and before that I was the Senior Director at the Environmental Defense Fund on Safer Chemicals Policy. I've worked on lead for about 30 years and on lead in food for about the past 10 or 15 years. I have made food as a chemical engineer. I've made food, drugs, pesticides, and the like. That helps us understand the opportunities that we're confronted with here. I was involved in the California legislation and negotiations that exempted infant formula. They were originally in the bill. It was exempted because of the unstable market as all those recalls were happening, but also because there was a lack of data. We now have the data from Consumer Reports, from Clean Label Project, and Florida calling for those changes. Fully support adding it to it. One of the things we found, much of my focus has been on baby food. One of the things we found on baby food is that parents can handle this information. They have seen this information for a year. The people have not freaked out over it. They've not stopped buying baby food. They've not shifted to their own. They're buying these products. It's actually expanded the market, and they're trusting the companies that have been more transparent. That's why we need to see this extended to infant formula. We also am asking for 2 amendments in here that I think have been offered. And the reason for those amendments is as we evaluated the work on baby food, we realized that many parents don't go to the store to pick it out. They go online and look for the brands they like, want to see these results, and the companies weren't making it available. They were requiring that you actually purchase the product, or you go to a store and handle it, or that you enter many digits, or that you also had, if you go to the product details page, you couldn't get access to the testing results. There weren't links to make that happen. The amendments fix that problem. The adding infant formula extends this approach that has worked so successfully, and it makes a difference. Thank you.
We're open for questions.
Vice Chair Collison.
Thank you, Madam Chair, and thank you, Delegate, for bringing this bill. And I think that my question is actually for Mr. Nelter. I was reading the letter from the Maryland Department of Health, which is a letter of information. They're not taking a stand on it. But what they seem to be saying is that FDA is already doing this. We don't really, and the process of testing is not completely fleshed out yet, and everything is still in process. They are, if I'm reading between the lines, they're saying the bill is premature. Do you have a response to that?
What FDA does is set limits on the amount of these toxic elements in food based on the highest 5 or 10%. It's not based on what can be achieved, but what they've seen on the marketplace. What this bill does is it engages market forces by letting parents choose the brands with the lowest levels. It's that variation in the level, the fact that some are high and some are low, that gives parents choices, and as a chemical engineer, forces me to as a chemical engineer to find the best product.
Delegate White Holland, followed by Delegate Hill.
Yes, thank you, Madam Chair, and Delegate, I do appreciate you bringing this bill forward, especially as a new mama. I really do appreciate you elevating and championing this issue. I wanted to go back to the letter that the Maryland Department of Health offered, as they also elevate concerns about how raw data is presented and how it could be interpreted by parents. And so I wanted to know, given the amendments that have been offered and elevated in Mr. Let me get it right. Nelter's, Mr. Nelter's testimony, and that I believe you accept as a friendly amendment. How does the amendment speak to some of the concerns that were raised related to the raw data and some of the information that is offered to parents that may also give them the opportunity to have additional choice in all of that? So can you share a little bit about how that may speak to some of the concerns that they raise about some of the data being presented?
Do you want me to reply or?
Whoever is best to answer, and maybe it's Mr. Nelter because of his work in California.
Yeah, what have you found?
So what we found is that many of the companies were restricting access to the product by putting it, and when it's online, it's walled off in a separate section that isn't linked to, so parents can't find it.
Like a firewall.
They also, many of it, like a firewall, although you can't get to it from the product details page. And so what we found is that when people are looking for it, they can't find it, which is important. Also, the companies tend to take the opportunity to explain the data, and that's been really effective. They give context of what levels are out in the environment, and they provide explanations. It's that context that the companies provide that helps parents make choices. The raw data itself has to meet strict quality control standards, and they have to go through a laboratory method that's developed by FDA to make sure it's good data. We have looked at the data that's been posted. We found some minor problems that the companies corrected, but by and large, it's been very helpful and reliable. And parents have handled this information and not overreacted.
Okay, and if I may ask a follow-up, Delegate, is there anything else that you would like to add based on what Mr. Nelter shared?
Yes, thank you. If you would recall back in the original bill, it reads that all products need to meet International Organization and Standardization, International Electrotechnical Commission standards, according to the FDA for analytical methodology, as well as it demonstrates proficiency in quantifying each toxic element to at least 6 micrograms of the toxic element to kilogram of food through an independent proficiency test by achieving a Z-score that is less than or equal to plus or minus 2. I don't care what kind of food you're eating, it has to meet that requirement. And once it does, you're good to go. And you shouldn't have a problem citing that anywhere and being fully transparent on that.
Thank you, Madam Chair.
Delegate Hill.
Thank you, Delegate, for this bill, and thank you all for being here in your testimony. The Infant Nutrition Council of America has a letter. I don't know if you had a chance to read it yet, Delegate. Their concern.
Oh, yes, he will be coming up to speak.
Right.
But yes, we've become really close
Okay,
as
so
of
their
last night at
concerns-
6 p.m.
In addition to the ones that the vice chair mentioned, they also make a couple of points that there's a reason, they suggest there's a reason why infant formula is classified different than baby food. They also talk about that it has much lower levels, in addition to the FDA not having determined yet what the levels of concern would be, and that there are other regulatory agencies like WHO, EU, and Codex who have standards that are being satisfied. So there's some concerns here about the bill on multiple levels. Do you have a response to that?
Yes. So, I mean, I've read the letter, and with all due respect, most of it is gaslighting. But outside of that, once you put aside the gaslighting and you have a real conversation about what the real issues are, it's a concern about profits, and it's a concern about the use of the word toxic. My request to them is that if they have a concern with how the verbiage is framed, that they provide alternative verbiage, that, and if it's found amenable, we'll move forward. But we cannot be disingenuous with the public with what we're finding. I mean, we're talking about as recent as last week. We've had an issue, January 9th, 2025. When Governor DeSantis comes out and says, we can do better, we can do better on infant formula. So that's my concern. They stated that they're 85% of the market and that they cover 100% with products on infant formulas. So that scares me as a red flag even more when I am saying, when that's the target of who's receiving infant formula in this country, and they may not be fully informed on what their children are ingesting. And they shouldn't have a problem revealing what it is, as long as they meet that 6 micrograms of toxic element, kilograms per food, whatever, with a Z-score less than plus or minus 2, then they're pre-approved before they even get into the grocery store. So if that's the case, we shouldn't be really having a conversation, because they shouldn't have a problem revealing what's in their food.
Thank you, Madam Chair.
Seeing no further questions, this concludes the testimony of this panel. Thank you very much. I do have one information. Craig Fellner. Mr. Fellner, you can get started whenever you're ready.
All right, good afternoon. My name is Craig Fellner. I'm the Government Affairs Director for the Infant Nutrition Council of America. INCA represents several of the leading domestic manufacturers of infant formula. Infant formula is the most highly regulated food in the U.S. food supply. Our industry currently tests for heavy metals under various international standards as part of our long-standing commitment to provide safe infant formula products. While INCA appreciates the intent of HB 196, this proposal overlooks important differences between infant formula and the baby foods currently covered under existing law. FDA announced recently it intends to set formula-specific action levels as part of Operation Stork Speed, an effort we support. HHS has also announced that it will publish a report in April on heavy metals, a precursor to them setting federal action levels. We are also concerned that HB 196 would require infant formula to bear a statement about, quote, toxic element testing, unquote. The word toxic is not only inaccurate as it relates to trace levels of heavy metals in the infant formula, but potentially alarming for parents. Again, The FDA has stated that heavy metals in infant formula do not indicate, quote, a public health concern, unquote. Absent such a demonstrated concern requiring formulas to bear the word toxic might mislead parents and caregivers into thinking that these products are unsafe. We do not recommend any actions that might unjustly erode confidence in the U.S. infant formula, in U.S. infant formula that meets all U.S. FDA requirements. Further, it is worth noting any product labeling changes required to comply with this proposal would be functionally required nationwide as retail partners determine product distributions, not infant formula manufacturers. This too mirrors the approach taken by California, Virginia, and Illinois, and a pending proposal in New York. And let me just conclude. I have met with Delegate Tavares, and we had a great meeting yesterday. We intend on working out our concerns and our differences to get to the same goal that we all want, which is transparency and informed parents. Thank you so much.
Do I have questions from the members? Delegate Hill.
Thank you. Can you respond to what Florida found when they tested these 24 samples and found elevated levels? If it's so well regulated and it's so different from baby food otherwise, what are we seeing here? Is there some misrepresentation or is this information accurate?
Yeah, thank you so much for the question. I appreciate it. We actually are in the process of trying to get their methodology and to get their testing that they did. We don't have access to that. We would love to get that, and we hope to get that soon to see how the testing took place and the methodology they used, but we don't currently have that. So once we get that, we'll be able to take a look at that and give a response, but we just don't have the specifics about it right now. We're trying to get it.
What your industry's in other words, if you test your own formulas, do you know what you think you're coming in at?
We absolutely test our heavy metals content at all of our facilities, and we are absolutely 100% under the international standards that you referenced earlier.
All right. Are you able to share that information with the committee? Get that to us?
What the international standards are?
No, we know we can find out what the standards are, how your members of your association, what levels you all, on average, for each company, what are the levels that you all have?
Yeah, and it's something we do share with FDA, and because as you pointed out, they are working on a national standard. I would have to go back and see what my members can do as far as shareable stuff, but we do have a couple of members that share heavy metals and information on heavy metals in infant formula, and let me just say, almost goes without saying, but we don't put heavy metals into our infant formula. It's naturally occurring, obviously. And it's naturally occurring in our ingredients, as you probably read in that longer letter that we jokingly said that we may publish at some point. We do have an FDA program that we test our ingredients on when it comes into our plants, because if you think about it, the biggest thing for us, being having dairy as an ingredient is there's naturally occurring heavy metals in the ingredients that we use. So we absolutely do that as the ingredients come in, and then we do the testing before it obviously leaves the facility.
All right. Thank you. Thank you, Madam Chair.
Delegate White Holland.
Thank you, Madam Chair, and again, thank you for being here and offering some your comments here regarding this bill. Wanted to know, and I also appreciate you indicating that you're willing to sit down and work with the committee, and looking forward to having you in subcommittee as well. But can you expound upon, because you mentioned that there are some concerns in the use of the word toxic, and then you also, again, express a willingness to work out any issues. And so can you elevate what are some of the amendments or things that you would propose that can address some of the concerns that you've raised, while still making sure that the intent behind greater transparency and ensuring that parents can make informed decisions when they're purchasing these products can be maintained?
Yeah, thanks for the question. I appreciate it, and we 100% look forward to working with you and Delegate Tavares on this as it moves forward. I don't have anything to share today, but if I could just expound a little bit on that concern. To us, when you talk about the toxins or toxic, all of our products are testing under the international standards. And when you look at the standards for heavy metals, if you're under the value of the testing, then that is the acceptable level, obviously, with international standards, and it will be in the United States. So we get a little anxious when we see the word toxic on our products, because our products are underneath the acceptable levels. And to us, something would be toxic if it was ingested at higher levels, and our products are under the international standards. But we 100% look forward to working with you. And I don't have anything to share today, but we are working on it right now, and we have some ways that we can address that. Thank you.
Did you have a follow-up question?
Yeah, and if I may, Madam Chair, just very quickly, I think that it was mentioned in the previous panel that even providing that level of information is still helpful for parents to make an informed decision, and it hasn't impacted their ability or their desire to still purchase these products. And so I think the concern then is, while there might be some concerns on your end regarding the word toxic, but it still appears, based on other states that have this in place, that it hasn't prohibited their ability to still purchase. If anything, it helps to make a better informed decision. And so can you expound upon that in particular, given what we've heard prior?
Yeah, thank you for that question. I would just offer this. When you talk about baby food, and when you talk about food for children that are over 2 years old, we think it's a little bit different than infant formula in that we're the sole source of nutrition for an infant 0 to 1. And we have always said you should best breastfeed your babies, and moms do it as much and as long as they can. But if they can't, and for whatever reason they go back to work, or they supplement it, or they do half and half, when you go into a grocery store and you look for infant formula, it's either breast milk or infant formula for nutrition for your baby, for your infant. And so our take on it is, when you look at baby food, which is over 1 year old, and you look at other types of food for children and older toddlers, if a mom or dad looks at that package and they just don't like what they see, and they do some research, whatever, they can put it back in the shelf, and they can go to the fruits, and they can get other things. But the reason why we are concerned about it is because we're the alternative, sole alternative to breast milk. And so, and that's why we are, somebody said, pre-market approved, and we're closely scrutinized by FDA before we even put a product on the shelf. And in fact, if we even want to change the packaging of the product, we have to resubmit information to the FDA, and they have to approve the new packaging. But thank you very much for the question. I appreciate it.
Seeing no other questions, I want to just posit this to you, because I think you are hearing there is concern in this committee. So I would ask, given your opposition and your willingness to work with the sponsor, that you find a public-facing resource, because we did look on your site, and there is no public-facing resource on your site that speaks to the testing, that speaks to the levels, that speaks to the fact that you are within the FDA regulations. And I think there's also a concern because, to your point, baby food is a little different than baby formula, but baby formula is for infants, which are smaller, which means that these levels have a greater impact on their developing minds and bodies. So I think if your testimony remains that having that packaging could be of a concern, could have a chilling effect, which is, I think, what I'm hearing from you, I would ask that you find some data to support that, given that we know that there are states that have taken additional efforts and have not seen that chilling effect. So if we could work with the bill sponsor so that we can be fully informed as we consider these.
Yeah, absolutely. Thank you for the urging, and 100% we will. Thank you so much.
Thank you very much. Seeing no further questions, this concludes the bill hearing on House Bill 196. We are going to move to House Bill 380. Just for planning purposes, I remind the committee that we have 2 more bills. It is still early in the session, and our days are going to get longer, and all of these bills are going to go to subcommittee. So try and adhere to the 1 question rule, and more importantly, that your question be shorter than the answer. Thank you. And when you are ready, go ahead and get started.
Good afternoon, Madam Chair, Vice Chair, members of the Health Committee. For the record, I'm Delegate Steve Johnson, here to present House Bill 380, State Board Examiners in Optometry, Examination Requirements, and Time Period for Inactive Status. This bill is a modernization bill. It updates the State Board of Examiners in Optometry to reflect current national examination standards and establishes the time period for inactive status. These changes are important in light of recent developments. The National Board of Examiners of Optometry, which administers the National Optometry Examination, announced in 2023 that it restructured the exam. After review, the Maryland Board determined that its current standards are obsolete. House Bill 380 requires applicants for licensure to pass all parts of an examination determined by the board. Additionally, it also removes the mandate that the board administers the examination. Currently, status does not provide a specific length of time a license may remain in inactive status and offers no mechanism for the board to take action on inactive licenses. This has resulted in more than 300 licensees on inactive status. Some of these may be abandoned, some licensees may have relocated or retired, but the board cannot act and these licensees could remain indefinitely. This bill establishes a 6-year time limit for inactive status for licenses, improving the oversight and allowing the board to maintain accurate licensure records. House Bill 380 will help us ensure that Maryland optometrists provide high-quality care and reflects current emerging developments in education, training, and clinical practices. With that, I ask for a favorable report on House Bill 380. Thank you.
Good afternoon, Chair Bagnall and Vice Chair Collison and members of the committee. My name is Catherine Carter. Some of you know me as Cat Carter. I serve as the consumer member and the treasurer for the Maryland Board of Examiners in Optometry. Joining me today on behalf of the board is the board's executive director, Gwendolyn Joyner, who is here to answer questions that you may have. Thank you for the opportunity to come before you to testify in support of House Bill 380. Our written testimony has been submitted as requested. We are asking for the Health Committee's support of HB 380. The bill amends language related to the board's licensing processes and procedures. Specifically, it removes old language that required the board to administer the jurisprudence exam, gives the board the authority to consider recent changes to the National Licensing Examination. The organization who administers the national examination is the National Board of Examiners in Optometry, NBEO. In 2023, the NBEO announced that it restructured the national exam and the assessment of skills necessary to meet the minimum qualifications for entry into the practice of optometry. Upon review of licensing applications that included the restructured examination administered by the NBEO, the board concluded that its current licensing standards are obsolete. To account for the recent changes to the examination and assessments, the board supports an amendment to the current statute that requires applicants for licensure to pass all sections of each part of the examination as determined by the board. Also establishes an expiration period for inactive licenses, which is consistent with other professional healthcare licensing boards. The board believes these amendments will, one, help the board carry out its mission to protect the public, ensure licensees are equipped to continue providing high-quality optometric care, aid the board in promoting and maintaining high professional standards for practice of optometry, allow the board to improve and streamline processes, and bring Maryland's regulatory framework in alignment with national trends in optometric education, training, and clinical practice. For these reasons, the Maryland Board of Examiners in Optometry respectfully requests a favorable report on HB 380. Thank you for your time.
Before I take questions, I will also note that there is no opposition to this bill. Are there any questions from the members? Delegate Alston.
Thank you, Madam Chair. Recognizing there's no opposition to the bill, I do want to ask, is there a reason why we're changing? Are people having problems passing the different sections of the test?
The National Board of Examiners recently changed their testing. They restructured the exam, and the board felt after reviewing their the new exam requirements that they would prefer that all of their licensees pass the exam, all three parts of the exam. Currently, they can pass parts 1 and 2 of the exam of the National Board and still become licensed. However, our board decided that they wanted the licensees to pass all 3 parts of the exam due to public safety.
We have an optometrist in-house. I would just like someone to talk to her. I trust her opinion that works in general. She's a member of the assembly.
Yes, Delegate Miller?
Yeah, if someone could just talk to her about the changes that are being requested.
Absolutely.
Thanks.
Seeing no further questions, I believe this concludes this hearing, yes, on House Bill 380, no pun intended. We are going to conclude with House Bill 377, physician assistance parity with other healthcare practitioners. And Delegate Johnson, do you want to invite your panel up? Yes, I know it's the eyes, not the ears. I have on your sponsor panel, let me just make sure I have it right, Robin Elliott, Deanna Bridge, Najera, Kelly Schultz, Jane Kranke. And you can start whenever you're ready.
Thank you. Good afternoon, Madam Chair, Vice Chair, members of the Health Committee. For the record, I'm Delegate Steve Johnson, here to present House Bill 377, physician assistance parity with other healthcare practitioners. This legislation is important to ensure healthcare system works effectively, efficiently, and recognizes the role that physician assistants already serve. So, why is it time to update our laws and recognize the role of the physician assistants? The Maryland General Assembly has already updated our law to recognize the role of other advanced practice clinicians, such as nurse practitioners in a wide range of healthcare settings. I've introduced House Bill 377 because it is the right time to take similar legislative action regarding physician assistants. House Bill 377 builds upon our prior work. In 2024, the General Assembly enacted House Bill 806, Physician Assistant Modernization Act. This reframed the physician assistant relationship as a collaborative practice arrangement rather than one of delegation. The roles of physician and physician assistants had already evolved. In 2024, we realigned the statute to reflect the existing roles of these clinicians. House Bill 377 is the next step in our work. We should update our laws to reflect the physician assistants plays a similar role to other advanced practice clinicians. Rather than introducing a series of individual bills, I thought it more effective to consolidate into one bill. House Bill 377 simply adds physician assistant in 22 sections of the law where advanced practice clinicians are already included. House Bill 377 also supports the implementation of the Rural Health Transformation Grant. In December, Maryland was awarded $168 million for the first year of a 5-year federal Rural Health Transformation Grant. House Bill 377 reflects the federal guidance directing states to help rural providers practice at the top of their license and develop a broader set of providers to serve the rural community's needs. Since the guidance places a special emphasis on the role of physician's assistants, House Bill 377 can be part of our state's strategy and successful implementation of the Rural Health Transformation Grant. House Bill 377 gives Maryland another tool to reduce ER wait times. Maryland struggles with some of the longest emergency room wait times in the country. Hospitals face particular challenges with psychiatric admissions. Maryland's law contributes to this challenge as it has not been updated to reflect the role of physician assistants in emergency departments. Under current law, voluntary and involuntary psychiatric admissions require 2 clinician signatures, with the physician needing to be the first signatory. Physician's assistants are not recognized in the law as a potential second signatory, despite physician assistants being the most common advanced practice clinician in the ER departments. House Bill 377 would update the law to add physician assistants as an option for a second signature in voluntary and involuntary admissions. Already at least 7 other states explicitly recognize physician assistants as secondary signatories in involuntary admissions: Alaska, Arizona, Florida, Idaho, Maine, Nevada, and New Hampshire. House Bill 377 recognizes the role physician assistants play in many settings from primary care to hospitals. House Bill 377's provisions include recognition that physician assistants can prescribe emergency use epinephrine for use at youth camps, along with physicians and nurse practitioners. Extending the ability to admit pregnant patient to an infirmary in a correctional facility to physician assistants, and allowing physician assistants to sign medical leave slips for state employees. I am committed to working with all the stakeholders through this whole process, and with that, I would ask for a favorable report on House Bill 377.
Good afternoon. Robin Elliott. I'm here today on behalf of the Maryland Academy of Physician Assistants. You will hear from the physician assistant experts who work in these settings every day. I just wanted to spend my time lifting up 2 items for which I think there will be a lot of discussion. One is around involuntary admissions, and the idea is to allow PAs to be the secondary signature. There is support in your packets from the Baltimore Behavioral Health System, from NAMI, and from the Maryland Rural Health Association, exactly because we know that people are getting caught in the waiting rooms waiting for admissions. And I'm also happy to answer questions. You're going to hear some discussion about the need or perceived need to have a certification of expertise. The second issue you may hear discussion about is physician assistants as primary care providers. For some of you, this may be deja vu. Literally last week, there was a lot of discussion about some Medicaid regulations that didn't move forward, but I just want to say that physician assistants are recognized as primary care providers in our Medicaid regulations. That was never proposed to be changed. And they are also recognized as primary care providers under Medicare. I just want to put an asterisk. We did notice upon fresh eyes reviewing the bill before the hearing that there were a couple places where the committee may be interested in adding nurse midwives and licensed certified midwives. I've discussed it with Delegate Johnson and, of course, the physician assistants, and we are happy to flag those places for you. Thank you so much.
Chair Bagnall and the esteemed members of the committee, thank you so much for the opportunity to provide testimony today. My name is Deanna Nahara, and I have been a PA for nearly 20 years. Working primarily in Maryland, I currently split my time between a local health department and a community emergency department. Physician assistants, or PAs, provide care in every type of setting. We're able to perform physical exams and telehealth appointments. We order labs and imaging, prescribe medications, and refer to specialists. You've probably encountered a PA in an office setting, in the hospital, in the operating room, or maybe even as part of a mobile home care team. Patients and health systems in Maryland value the care that PAs provide. But there are parts of the Maryland law that have not been updated for years, and Delegate Johnson's bill addresses those areas. As you heard, Maryland's the recipient of significant funding through the Rural Health Transformation Program. These funds are an opportunity for Maryland to address persistent healthcare access issues in our rural communities, and PAs want to be part of that work. The federal guidelines emphasize removing barriers to practice for PAs and other advanced practice clinicians. We know that we need more clinicians, but that's not going to happen overnight. What we can do is fully utilize the PAs that we have right now, allowing clinicians to practice at the top of their license so they can provide care to the greatest number of people. This bill helps with an immediate impact on the current workforce, removing barriers for the individuals that need the care the most. Supporters of this legislation include major health systems, employers, and the Board of Physicians. Most importantly, it's supported by mental health advocacy organizations and other direct care providers. This bill will help us to continue to care for our patients in the best way possible. I ask that you fully support House Bill 377.
Madam Chair and delegates, my name is Kelly Schutz, and I've been a practicing emergency medicine PA for the last 27 years and an emergency medicine director for the last 6 years, practicing in multiple Maryland hospitals, including Baltimore City. Prolonged stays and delays of care for our psychiatric patients are a well-known problem within the medical community. Delays are further impacted by the inability of our PAs to be the second signatory on involuntary forms needed to initiate a psychiatric transfer or admission. This impact is most significantly felt at our smaller community hospitals during times of single physician coverage where only the physician can be the signatory, which causes delays in decision to admit times. As referenced in the submitted written testimony, you can see that the overall throughput of psychiatric patients from the time they come in to the time they leave is roughly cut in half when there are 2 signatories available. The same trend continues if you isolate for only admitted patients. My hospitals with the least amount of resources and the greatest amount of single physician coverage time has a decision time almost 7 hours longer than our hospitals with 2 signatory physician coverage. Every day, our PAs actively manage and treat psychiatric patients in the emergency department and are already available and a resource that is capable to be the secondary signatory. We conduct histories and physicals, order medication, including medication for acute agitation and psychosis. We interview family members and discuss management with our psychiatry team. Many times, part of our job involves teasing out whether a physical complaint stems from an underlying psychological problem or if the display of concerning behavior is a manifestation of systemic disease. I urge you to allow PAs to be included as a second signatory to move the needle in providing timely, quality care for our psychiatric patients. Thank you.
Good afternoon, Chair Bagnall, Vice Chair Colson, and members of the Health Committee. My name is Jane Krinke. I'm here on behalf of the Maryland Hospital Association and proud support of House Bill 377. I think you've heard from each panelist some of the same things you'll hear from us at the hospitals. PAs are an essential member of the healthcare workforce. As advanced practice providers, they help ensure access to care, especially in rural and underserved communities, as well as community settings like our urgent care centers and primary care offices. With the legislative change that Delegate Johnson mentioned in 2024, PAs are now working as collaborating providers. And so what this bill really does is aligns other parts of the statute to allow them to work at the top of their license, which, given the healthcare shortages, the increased demand for healthcare, that's really what we need, everyone to be working at the top of their scope in a team. That's where healthcare works the best. And allowing PAs to evaluate and have that second signature on those involuntary and voluntary admissions helps decrease delays to behavioral health care, which, as you know, is a huge problem, especially in the emergency departments. So for all those reasons, we are supportive of House Bill 377. We think it's a great pathway to ensure the PAs are able to practice at the top of their scope. And we ask for a favorable report. Thank you.
Thank you very much for your testimony. Are there any questions for this panel? Delegate Lopez.
Thank you, Madam Chair, and thank you, Delegate, for introducing this bill. So I was looking through the written testimony, and you've got lots of favorables, but there's one unfavorable from the Public Defender's Office, who I've worked with a number of times. And there's a line on the second page of their testimony that caught my attention. Basically, it says, if this bill were to pass, the state would authorize an independent practitioner, one without the depth of psychiatric residency training, to unilaterally implement a court-mandated involuntary commitment process. And to me, that sounds kind of extreme. So I wanted to give you an opportunity to clarify a bit what that meant, or if that's an accurate depiction even.
I'm happy to take that question. So as is very clear, two pieces, very clear in the law is that the PA, in this case, in the bill, would be the secondary signature. So there is no pathway for any clinician actually to make a unilateral decision. There always has to be two signatories. It could be, it has to be a physician, and then it could be a physician, psychologist, a licensed clinical social worker, or a licensed professional counselor. And so the bill adds PAs. The second is that PAs do have education and experience in psychiatric conditions. We've heard from them about their firsthand experience. I'll just also point out that in hospitals, and in 2024 in your collaborative practice bill, very much acknowledge that hospitals have the responsibility in credentialing for anything considered an advanced duty. And so hospitals make determinations every day about all kinds of providers and whether they can work in ORs, ICUs, or emergency departments. So there's already a system in place to ensure, whether it's a physician or a PA or nurse practitioner, that they have the right education and experience.
Thanks. Thank you.
Thank you.
Delegate Alston, followed by Delegate Worman.
I think she was first. More.
Delegate Worman.
Thank you, and thank you so much for your testimony. And based on also the public defender's written testimony, I just want to clarify, do any of the proposed changes in the bill alter the involuntary admissions process?
No.
Okay, thank you.
Delegate Alston.
Thank you. So my concern or question is, if PAs generally work under the supervision of a licensed medical doctor, is that accurate? An accurate representation of the scope of practice?
The framework is different. It's actually they work in collaboration, not under the supervision.
So they have independent authority from a doctor? They can operate without a doctor being present or overseeing their work?
Let's clarify operate, because that can have a different meaning in health.
Practice. They can practice.
So in order to practice, PAs have to have a collaborating physician or physicians. But in terms of kind of everyday sort of what they do every day, that is not supervised by a physician. They don't have to be on site. They can consult with that physician. They can consult with a variety of other clinicians. There's no longer a supervisory arrangement.
Thank you. And the reason for the concern is if this collaboration, how independent are they when maybe their supervising or collaborating doctor is asking them to be the second signatory on one of these involuntary commitments or emergency commitments? So that's where my concern would be. Or is it going to be the case that it has to be a doctor that's unaffiliated? Like, how does this work to make sure that we're getting a true independent assessment and not one that's coerced?
Yeah. So physician assistants, just like any other licensed individual, they have to abide by ethical standards, which includes not being coerced or pressured into making some kind of medical determination. And sort of picturing emergency departments, the attending physician isn't necessarily the collaborating physician. And in hospitals, there could be this question, the attending physician is kind of the top level decision maker. There are other clinicians, including nurses, nurse practitioners, other PAs, and there is not a, how should I say, necessarily the supervisor is not necessarily the collaborating physician. I think I went around in circles. I apologize. I'm happy to chat more offline.
Thank you.
Seeing no further questions, that concludes the testimony of this panel. Thank you very much. I do have one more favorable, Michael Tran.
Good afternoon, Madam Chair, Madam Vice Chair, and committee members. For the record, Michael Tran with the Maryland Board of Physicians. First off, just want to thank the delegate for his leadership and work on this bill. The board is here as a Me Too and urge a favorable report on HB 377.
Thank you. That was excellent testimony. We do have a question. Before you run away from Vice Chair Collison.
Madam Chair, for your indulgence. Following up on Delegate Alston's questions, do you have any concern, as the board discussed this bill, is there any concern about the PA being the second signatory in the involuntary placement process?
That's a good question. So with this bill, we have discussed that what's included in it is kind of just a process that we already believe would be covered under the collaboration agreement, and that relationship can construct what the PA can do and what the physician is comfortable with. So as long as that would be detailed in a collaboration agreement that the physician or physicians and the PA would have to discuss before their employment, we believe that that structure and those responsibilities fall within that conversation and are okay with the board. I think it depends on whether or not it's subjected to the PA or the physicians on whether or not they would like the PA to do that. But the collaboration agreement would be the area where this discussion can happen and the physician can give that authority. Just because it's the PA is allowed to do it, the collaboration still creates this construct of the relationship between the two and what the PA can and cannot do. So from our reading, it is still that the collaboration agreement would be ruling over all of it, and that the PA would be subject to what the physician or physicians would like that PA to do. So I hope that answers your question.
I follow up. So I understand that, but what I hear Delegate Alston's concern being is that there could be a level of compelling a subordinate to sign off on something. Do you have was that discussed in terms by the board in that?
That specific aspect was not discussed with the board. I can bring that back and kind of gather that conversation and kind of see how that goes, and then get back to the committee with an answer.
Okay, thank you.
Of course.
And perhaps we could have that conversation and bring it back for the subcommittee.
Absolutely.
Seeing no further questions, we're going to go to a favorable with amendments. We have Steve Wise in person, followed by Steve Davis virtually.
Good afternoon, Madam Chair, members of the committee. Steve Wise here on behalf of MedChi and the emergency room physicians. And as you mentioned, Dr. Steve Davis is virtual and will be speaking for MedChi as well. By our count, there's essentially 13 tasks that are added here that a physician assistant would be able to do under the bill. Our amendments relate to 4 things. 2 of them deal with a voluntary admission. 1 deals with the involuntary admission, and Dr. Davis is going to speak to that. And then the 3rd deals with what you discussed somewhat already, and that's the PA being designated as a primary care physician. On the voluntary admission, if you look at the statute right now, every profession that can be the second signature on a voluntary admission is somebody who has some advanced mental health training. For physician assistants to do what would be considered psychiatric advanced duties, they have to get Board of Physicians approval to do that. It's basically considered above what every PA is trained for. There's an exception to that when you're in what's called an exempt facility. And with all of these admissions, we're usually talking about the emergency room, right? And the emergency room, the hospital, is an exempt facility. So they don't have to go to the board for those additional approvals because the thinking is the hospital will ensure there's adequate protocols. But the amendment we ask for is that you do require advanced duties when that physician assistant, in the very rare circumstance, but it can happen, where the physician assistant is not covered by that exempt facility exemption. So that's what we ask for as to voluntary admission. Dr. Davis again will talk about involuntary. And on the designation as a primary care provider, while that may be the case under Medicaid and Medicare, the change here relates to private HMOs and we think raises some other questions that we're still looking into. With my time up, I'll stop there.
And unmute. Dr. Davis, if you can go ahead and unmute and you can start your testimony.
Okay, thank you very much. Hi, Steve Davis. I'm a psychiatrist in Baltimore. And I've worked in many emergency rooms where involuntary certifications occur. The title in this bill talks about parity with other practitioners. However, I think for the involuntary certification patients, it's not really a parity issue because currently, if you don't have 2 physicians, it's 1 physician and a second person, that second person is always a licensed mental health professional currently. You'll notice that, like, for example, on page 6, lines 19 to 22, where it lists the individuals that can be the second signatory, it includes a psychiatric nurse practitioner, so somebody with advanced education and training in psychiatry, whereas a nurse practitioner who is not a psychiatric one cannot do that. They're not included. And because a PA is also lacks that dedicated education and training in mental health to the point where they get licensed based on that knowledge, you would be opening up the door for having constituents in the emergency room who may or may not need a psychiatric hospitalization. And if they are, first of all, you've got to determine, is this a medical problem or is this a mental health problem? Which is one of the reasons you have 2 different individuals evaluating them independently. But then with the, if you have a PA doing it, you're going to have a situation where if the physician evaluating the patient is not a psychiatrist and the PA lacks mental health professional licensure, then you're going to have people put into the hospital with their rights taken away without any mental health evaluation by a mental health specialist at all, which is different than what the current status is. That's why I think that those sections with involuntary should be stricken because it really lowers the requirements for evaluation. Thank you.
Thank you very much. And before I take questions, we don't appear to have written testimony. We don't have these amendments. So if you can make sure to share them with us and share them with the bill sponsor.
Can I respond to that, Madam Chair?
Yes,
So
go ahead.
I did meet with Delegate Johnson. I described them, and I have written them, but I haven't proofread them yet. So I will get them to him and the committee as soon as I can, as well as Ms. Elliott, who I spoke with last week.
And Vice Chair Cullison.
Thank you, Madam Chair. Steve, did I understand you to say that you might be open to, and your amendment would essentially say that anyone who was going, any PA that was going to take on that role as the second signatory would have to have the mental health certification training that they have to in other settings?
No. And let me explain. I was a little rushed with that, so I understand the confusion. If the PA is working in an emergency room where most of this occurs, right, most of these certifications, they're covered by an exemption under the advanced duty section of the law that says, hey, you don't have to come to the board because we trust the accreditations and the protocols of the hospital. We're not trying to change that. What we are saying is if you're going to allow a physician assistant to be the second signature on that voluntary admission and they are not in the hospital, they should have to have the advanced duties because outside of the hospital, there aren't those assurances that they've got this enhanced training.
And may I, Madam Chair? And like, what would be an example of outside of the hospital?
Well, it's a great question, and the law is a little tricky on this. The definition of exempt facility says that the person is in the employee, the PA, doctor, whoever, is in an exempt facility. It doesn't say employed by, it doesn't say, so my answer is a little hazy because the law is a little hazy. But the intent would be, if they're working in that hospital, they have other advanced duties, in the same vein, this person would be covered by that exemption. It'd be helpful if the law said something like credentialed by or, but it doesn't. It just says in.
Great, thank you.
Yeah.
Delegate Lopez.
I'm so out of practice. There we go. Thank you. Thank you, Madam Chair. I'm aggressively pressing this. So if I remember, I think it was the sponsor's testimony, it sounded like there's 11 states that are operating under basically what this law is, or what this bill is initiating. Can you tell us, in those 11 states, what problems you're seeing with this law in effect?
Yeah, I can't. It's a short answer. I think the concerns that Dr. Davis illustrated are our concerns are based on his experience rather than the law in the other states. But I will say that, and I don't know the law in the 11 states that were noted, but across the country, the independence, if you will, of physician's assistants varies. I would put Maryland in the middle. In some states, it's supervision. A few states have gone to independent, completely independent practice, and we're in the middle with collaboration as a result of the 2024 law, which many of us worked very hard on. So I think, I would like to know which of those three categories those 11 states are in, because I think that may be a factor in it.
Gotcha. Thank you.
All right, I see no further questions. I just had a question about, you had spoken to the collaborative care model, and I was a little confused about what you said, because I thought I heard you say, under Medicaid, we already have the authority to do this, but you were concerned about the private payers and the MCOs. Can you just clarify?
Sure. I was alluding to the fact that the proponents had said under the Medicaid and Medicare law, they can already be designated as a primary care provider. This section of the law deals with private HMOs, and our concern is what does that do to billing and other things related to the relationship in the private insured world versus the public, which is what they referenced. And frankly, we're still trying to get some answers on that.
Okay, I would appreciate those answers because the collaborative care model is an access model. So if we could understand what the concerns are, and hopefully we can also resolve those as well. Thank you.
We'll follow up with you. I have reached out to one insurer to find out some of these questions, but I don't think we've gotten all the answers yet.
Well, I see no further questions for this panel, so thank you very much for your testimony. We have one unfavorable, Sanjeev
Thank you.
Varghese. Thank you very much for your testimony. And Mr. Varghese, if you want to rejoin us, you're going to have to tell me how do you say your name because I think I've butchered it twice now.
No worries, it's much better than I've heard over the years. It's Sanjeev Varghese. Good afternoon, Chair, Vice Chair again. I'm Sanjeev Varghese. I'm the Deputy Chief Attorney in the Mental Health Division of the Public Defender's Office. As part of our role in the Mental Health Division, we represent every individual. I think I may have had a private attorney represent a client once in over the about decade that I've been doing this work. We represent every individual at involuntary admission hearings. That means after they've been certified and the like. Our concerns with this bill are that there is, as the previous testimony from Dr. Davis, I believe, was talking about, there is the potential then for having a physician and then a PA, for example, sign certs without having any further mental health treatment or training or skill sets. There is a vastly different skill set in their specialized training for mental health professionals versus the basic that is needed to be a PA. What we're asking for is that this minimum bar protect these individuals who are having their liberty taken away from them. We understand that there's a concern about access to care and people getting warehoused or held in the ED for longer periods of time. My chief of my division, Carol McCabe, went through and looked at the numbers that we have for the certs at the different hospitals. And she looked at the certs that took place at the end of December through January. And she looked at particularly Calvert County, the Eastern Shore, and Frederick, areas which are traditionally underserved. In the 27 cases where there were certs, 23 of those cases, the certs were done by 2 physicians. In 3 of the cases, the cert was done by a physician and an NP. And that that 27th case, unfortunately, we only have 1 cert in our records, and we're unsure of what the second cert was for or who did that one. We are not seeing that bottleneck.
Go ahead and complete your thought.
Thank you. With relating to those numbers, we also see that in the vast majority of cases, of those 27 that my chief looked at, the certs were all completed within generally minutes or an hour or 2 of each other. It's not as though there was a longer period of time. There's only one occasion where there was longer. That was on Christmas Day, where it took 8 hours for the second cert. Thank you.
Thank you for your testimony. Do we have questions for this witness? Oh, Delegate Mormon.
Thank you. Thank you for sticking with us for so long. I see that NAMI and the behavioral health system of Baltimore are supportive of this bill. Why would these organizations support the bill that you say would put patients at risk when they, arguably have patients at the top of their mind?
We all have the individuals, the patients, our clients at the top of our mind, but our motivations for helping can be different. And the individuals, for example, NAMI or others, may have a different approach for whether it's coercive, whether it's forcing people into treatment or the like. There is going to be a different motivation. We have to look at that when we're looking at any of the legislation.
Thank you.
Of course.
I don't see any other questions. I just had one question based on the studies that you cited. You had mentioned that they were all rural populations. Did you do similar studies of Baltimore City, Prince George's County, Montgomery County, Anne Arundel, some of these counties that have a high population of high utilizers?
Thank you. I'm sure my chief is watching now, and we can work on that. This was something she had been working on late yesterday through today, going through, this was her main task from the past few days. If that is something that we can start looking at as well.
I think it might behoove us to be able to do a comparison, because we know those counties have a high population of high utilizers coming through the emergency rooms, and they might be better representative of the access issues that we're trying to address. I see no further questions. Thank you very much for your testimony. This concludes the bill hearing on House Bill 377 and concludes our bill hearings for today. If I can just ask everybody to wait until we bring down the live stream.